Assalamu alaikum. We will start today's session. We have patient named Mr. John came with complaint of leg swelling. 55 years, Mr. John with complaint of leg swelling.
Okay.
Okay, ready?
Yeah.
I'll do the timer. You can see the timer now.
Oh, yes, I can see it.
Yeah.
Hello.
Hello there.
Hi, good evening. This is Dr. Turkawi. I'm one of the doctors in the clinic today. Am I speaking to to Mr. John?
Yes, I am.
And you're 65 years old.
55, yes, I am.
55. Okay, sorry.
Yeah.
I
It's,
understand that you came with leg pain. Can you tell me more about it, please? Leg
yeah,
swelling.
doctor. Yeah, yeah. I have this swelling since long time, doctor.
How much?
Maybe now more than 6 months.
Yes, okay.
And I guess it's day after day increase and increasing more and more.
Okay. And is there any change in the way that it's increasing recently, or has it been slowly growing?
Yeah, like slowly, doctors.
Okay. And how did it happen 6 months ago? Was it sudden or gradual?
No, doctor. It starts like gradual, not sudden onset.
Gradual.
Gradual
Okay.
onset.
Okay. And is there any pain with it?
Sometimes I feel pain, but sometimes also it's like on and off, doctor. It's not
Okay.
always there.
Can I see your leg, please?
Yeah, sure, doctor.
Okay. So meanwhile, while you're showing it,
Yeah,
so there, you said that there is pain sometimes with it. Anything that
yeah.
makes the swelling worse or better?
Um, Actually, I don't notice anything make it better, but
Mm.
I think when I hit my leg, I think it makes it bigger.
Mm. Okay. And
Yeah.
what? Okay. Okay.
Okay.
And
You can.
this redness,
Yeah.
has it always been there, or it is on and off?
No, it's on and off, doctor.
Okay. And is it hot?
No, doctor, it's not hot.
Is it tender, this red area?
No pain, doctor. I don't feel any pain there.
Okay. What about just gonna ask you more questions about it. So you had
Yeah.
this leg swelling over the last 6 months. It's been growing up slowly.
Yeah.
It's red in nature, and there is this small patch redness. Do you have any swelling anywhere in your body? What about the other leg?
Uh, no, in this only, doctor. In the
This
right
one
side.
leg only. Okay. And where
Yeah,
the
yeah.
swelling goes up to? Does it go up to your groin, or where does it stop, the swelling?
No, only to the level of my ankle.
Your ankle only.
Yes.
Any breathlessness with it?
Sorry, any what?
Any shortness of breath? Breathlessness?
No, no, doctor, I don't have.
Okay. And any
Sorry. Hello.
Your voice is clear,
hello.
Dr. Bassel.
Sorry. So any
Yeah.
swelling in your eyes, under the eye, your eyes?
No, doctor, no swelling under my
Any
eyes.
any breathlessness when you lie down?
No, doctor, I don't have.
Okay. And any swelling, breathlessness when you walk or
No, doctor.
no? Okay. And what about cough? Any cough?
No, doctor, I don't have cough.
Okay. And no chest pain with it.
Actually, doctor, I had chest pain before, and I was having like a heart attack.
You had a heart attack before.
Yeah.
When was that?
It was 2 years back, doctor.
Okay. And do you take medication?
Yeah, doctor, I'm taking some medication for the heart called blood thinner.
What's the name of the medication, please?
Aspirin, doctor.
Aspirin. Anything else?
Yeah, doctor. I'm taking insulin, doctor.
Insulin. Okay. For the diabetes.
Yeah,
Anything else?
I have. No, doctor.
Any other medical condition?
No, I have diabetes, doctor.
Okay, so diabetes and heart attack. Any blood clots? History of blood clots?
No, doctor. I don't have.
History of any arthritis or any joint pain?
This one only, doctor.
Okay, and the pain, is it in the joint? So I'm examining the leg, looking at the leg. Any pain in the any tenderness or pain while I'm trying to move it?
No, doctor. It's not painful. I don't feel
It's
it.
not. Okay. What about your water work? Is it frothy or
Yeah, doctor. It's so frothy.
frothy? Okay. What about your uh uh the color of the water work?
No, doctor. It's the same. No change.
Okay. Any weight loss or weight gain?
No, the same.
Fever?
No,
Okay. And abdo pain, tummy pain?
no.
Okay. Any loose motions?
Yeah, doctor. I had like sometimes lose motion. Sometimes also I feel hard stool. I don't
Mm,
have any regular bowel motion. I mean, it's
Any
alternating.
sickness? Okay. Any sickness?
Sometimes I feel full, doctor, but not feeling sick.
Okay. All right. What about any ulcers or soreness in your leg or anywhere else?
Yeah, doctor, you're right. Under my leg, right leg, there is big sore.
Okay. Can I see it?
No picture for that.
No picture for it. Okay.
Uh,
And so
it's
you
in
don't
the
have
side
any.
of my right big toe, doctor.
Okay. What about your blood pressure
No, doctor, it's controlled.
controlled? Do you
Yeah,
take medication for blood pressure?
no, doctor.
Okay. What about family history of similar condition you said?
My father was having diabetes and stroke.
Okay.
Yeah,
And any okay. What about drug? Are you allergic to any medications?
no, doctor.
Okay, good. And any recreational drugs? That might be a little bit sensitive question.
No, doctor. I don't share.
Okay. Any share needling or
No, doctor. I didn't take.
do you have any casual partners, sexual partners?
No, doctor. I have my partner, but I don't have any other casual relationships.
Okay. And what about smoking, Mr. John?
Yeah, I have those smoking. Doctor.
You do smoke.
Yeah,
Okay. How much and for how long?
around 15 cigarettes for 20 years.
Okay. And I for how many years? Sorry,
For 20 years. 20.
20 years. Okay. All right. Um, I believe smoking is definitely having an effect on your heart and your vessels, well, your blood channels because of your diabetes and of your previous heart attack. And I believe your condition now is also can be affected by smoking. So I highly advise against smoking, Mr. John. Okay. And we
Okay.
can refer you to smoking cessation clinic if you're happy with it.
Yeah,
Okay. And what do you do for living, Mr. John?
I'm accountant.
Accountant. So you're sitting around. Do you think sitting around make the swelling more?
Yeah.
Okay. And is this condition affecting your job or your life?
Yeah, doctor. Sometimes while sitting, I hit my foot without feeling that
Mm. Okay. And it does you don't feel the pain.
at all, doctor. Just
Okay.
hitting, and no
Mm.
pain at all.
Do you think your joint might be deformed and then it goes back to the normal shape sometimes?
I feel it's not going back at all to the normal shape or
Mm.
size.
Okay. All right. I'll start examining you and I might ask you some questions. Okay.
Sure. Yeah.
So I'm looking at the patient, looking at the foot. I've touched it already, and it's not hot. It's just swollen up. And is there any tenderness? Any tenderness? Is that my internet? Guys, can you hear me?
Yes, I can hear you.
Okay.
Yes.
Hello. Sorry, I
Yes,
had some connection problem.
it's okay. It's
Yeah,
okay.
it was I guess 9 minutes, so I will assume the timer.
So I'm
Yeah, still
examining
the
the foot
timer is
now.
there.
Is there any tenderness?
No tenderness.
No tenderness in the leg.
Mhm.
Okay, I'm trying to move any joint deformity.
Yeah, you feel it's
No.
deformed totally. Yeah, totally deformed.
Deformed. I'm trying to put the trying to compress the joint back. Does it go back to normal?
No.
No. Okay. And did you hit your foot with anything? Do you have any trauma, Mr. John, before?
Yeah,
Really?
doctor.
I think
Always
it's
while
it's
moving,
done.
I'm
Mm,
hitting the doors and I'm hitting the offices.
mm. And you don't feel it really. Do you
No,
think you
at
have
all.
any problem with your gait? Can you give me? Can you walk for me? Let's see.
Yeah, limping. Patient is limping.
Limping. So no foot drop, just limping.
Yeah, no foot drop.
Okay, so look, full, feel, move. It's not hot, and it is not tender, right? You said, I'm sorry.
No tenderness, and
Mm,
you
it's
feel
not
like
hot. It's just, is it
loose
beating
bones.
edema?
There is edema around. Yeah.
Beating?
Yes, pitting edema.
Okay, what about the legs? Any swelling? I just want to measure the size of both calves,
Yes, it's bigger in the right side than the left.
the whole calf. Any
Yeah,
tenderness?
not the calf, only the ankle.
No, I want to measure the calves.
The calf, the
Yeah,
pulse.
the
Sorry.
calf, the whole.
No, the same. No difference, no
Okay,
difference.
and the pulse is okay. I've measured the pulse area, but
You can't feel the pulse, the dorsalis beetle pulse in the right side, and the left side is weak.
okay. And sensation?
You can't feel your finger at all,
You can't. So up to where?
up to the ankle.
The ankle. Okay.
Yeah,
So examining the hands of the patient.
yeah. He don't feel the same in the gloves distribution.
Okay. And then what about checking for carpal tunnel?
No carpal tunnel.
No carpal tunnel. Okay. Fingers for tarring and beam brick.
Yeah, there is a lot of bent bricks
And tarring,
marks.
nicotine tar.
No nicotine tag,
No flap and trimmer.
no flapping film.
Okay. What about the pulse?
Pulse in the hands as well, difficult to feel.
Okay. Proximal myopathy.
No proximity.
Any walking aid next to the patient?
No, he can, but he's using medical shoes.
He's using what? I'm sorry?
Medical shoes.
Medical shoes. Okay. What about the eyes? Any pallor or jaundice?
No color on this.
Have you ever been told that you look yellow or pale, Mr.
No,
John? No.
no,
Okay. Lymph nodes in the neck,
no,
thyroid,
no.
listening to the heart.
Yeah, apex displaced little bit,
Mm-hmm.
and you can appreciate some crackles in the chest and
Okay.
congested neck veins.
Okay. So the JVB is raised, I'm assuming.
Yeah, yeah.
And, no, we don't have thyroid, right?
No
You said.
thyroid swelling, no change.
Else I want to check in the neck, but I forgot what. Oh, carotid bruit.
No carotid bleeding.
Okay, and then what about the abdomen? Any hepatomegaly, looking for NASH?
No hepatomegaly.
And
No
okay, any
splenomegaly.
striae in the abdomen or signs of
No,
Cushing?
nothing.
Okay, and just proximal myopathy, no proximal myopathy. Just examining the
No,
lower
but
limb for weakness or
yes.
anything.
No weakness, but pins and needles, sorry, the pinprick and all modality of sensation
Mm.
and ankle, both sides disappeared.
I just want to examine the patient's eyes with slit lamp and fundoscopy. Um,
Excellent. Yeah,
um,
there is
mm,
exudate, hard exudate, and there is retinopathy in both
okay.
eyes.
How is your vision, Mr. John?
It's blurred, doctor, blurred. I
Mm,
am not seeing well.
I'm sorry for that. So, Mr. John, do you think you're well supported at home? Does your family, are they able to help you,
Yeah,
especially with
my
your
partner
joint?
helping me,
Mhm.
doctor. 1 minute and 30 seconds remaining, okay? Because
Okay.
there was lag. Yeah.
Yeah. Okay. So what's your major concern, Mr. John?
Why, doctor, this leg not corrected? It's always being like this deformed
Mm.
and never back to the normal shape. Why
Okay.
like that, doctor? Yes.
So, Mr. John, I believe you have the diabetes and the heart attack before. Your arteries and veins, which are the blood channels, are not in the perfect shape, especially with the history of smoking. How much alcohol do you usually drink?
I'm using around 5 units per week.
Okay. I so the all these symptoms that you have, the tummy problems, the numbness, the joint, the frothy urine, and all of these symptoms, even the vision, are related to your diabetes control. It's very important. Do you think you're strictly continue taking insulin?
I am taking, doctor, but I don't know why my blood sugar always high.
Okay, and you definitely take your dose every day.
I am taking, yes, doctor.
Okay, and how are your readings? Are they high?
Yeah,
I think we will need to admit you, do blood test, and fix your insulin, and then everything else should be corrected over time. Some of these things might not be corrected, but we will try our best to decrease the effect of the diabetes on your organs. Okay?
okay, doctor. Thank you.
Yeah. Thank you.
Okay, so I give 1 more minute for time lag.
Thank
We
you.
can
Okay.
now start the examiner time. Yes, please.
Okay. So
What's your
what?
case?
So this was a 55 years old gentleman who presented with joint swelling and deformity that has been going on for 6 months with a diabetic ulcer and peripheral neuropathy with vasculopathy as well. It looks like an uncontrolled diabetes with a lot of complications, including query nephrotic syndrome because he got frothy urine. He have a history of heart attack and diabetes, and he smokes. So gastroparesis, neuropathy, as I said, he have weak pulses and visual affection as well. I understand that his diabetes is very much uncontrolled. I'm not sure whether this is a Charcot joint or whether it's a mixture of Charcot joint and the neuropathy. And I believe this patient needs to be admitted for the urgent diabetic control and managing of his complications.
Excellent. So what's your differential in this patient?
The differential of the leg of the swelling of the foot.
Yeah, yeah.
So at the beginning, before seeing the patient, I was thinking of lymphedema. Um,
Okay.
However, looking at this joint swelling, so I would be thinking of the Charcot
Excellent.
joint. That would be the
Yeah.
top of my list, as I said.
Okay.
And then we can look at septic arthritis, maybe trauma related because of his repeated trauma secondary to the neuropathy, trauma related swelling. It could be inflammatory as well, arthritis, and it can also be degenerative like osteoarthritis or so. Um, Yeah.
Okay, give me one more related to blood pressure, blood sugar, diabetes, I mean, uncontrolled diabetes, and in the bone, related to the bone and
Yeah, I
joint.
like it.
What's excellent? Yes, that's it. Okay. How would you prefer to manage and investigate this patient?
Okay, so he needs a very big multidisciplinary team. He will need probably the tissue viability nurse because he have very weak pulses. He will need the diabetic nurse to increase his insulin, and he will need the endocrinology consultant. We would also need to involve the physiotherapist and the occupational therapist to help him with walking aid. We will need strict diabetic control, smoking cessation, clinic involvement. The GP need to be involved, and the community nurse as well. I believe he will need a cardiovascular involvement because of the history of the heart attack and whether he's at risk of developing another one. And I believe he is. Nephrology as well.
Mhm. Okay. And what team concerned for the joint and deformity? Did you invite
It can
them?
be trauma and orthopedic.
Excellent.
Yeah,
Okay,
it can be.
orthopedic and orthosis. Yes.
Yeah.
Okay. And for the management plan,
So
uh,
I would like to admit him, as I said. The first thing I would do is
yeah,
measuring his blood sugar, hemoglobin
excellent.
A1C, doing a blood gas, looking for any signs of any acidosis or any kind of chronic
Okay.
acidosis. Can be because of the kidney or the or DKA or anything else. Doing
Mhm.
a basic full blood count, looking for anemia and high infection markers. Renal
Mhm.
function test, looking for any signs of glomerulonephritis or electrolyte disturbance. Urine dip and albumin creatinine ratio if need be. I would also need to do an X-ray to the foot, and he needs so investigations for his eye, probofundoscopy, referral to the ophthalmologist. We
Okay.
will need to do a flow, probably arteriography, so CT arteriography for or CT angiography for the legs. Uh, I'm not sure whether we will need to do an F conductive study. I believe we need recommendation from neuropathy, neurology regarding the numbness and diabetic neuropathy.
Yeah,
Um, and yeah, he probably will need physiotherapy, occupational therapy. Definitely, definitely. Try to give
excellent.
him shoes and stuff to put the joint back
Yeah.
in.
Okay. Yeah, what the team need to be involved also, apart from doctors.
The nurses, the dietitian, nutritionist
Excellent.
to
Yeah,
advise
the
him
dietitian.
regarding
Yeah,
his
this is the one I want to hear. Yeah,
diet.
dietitian, because this patient is not compliant to diabetic diet.
Yeah.
He is, yeah, he's not controlled with the diabetic diet. Okay. Okay, that's enough for this space. Thank you, Dr. Rinaz.
Thank you so much.
Yeah, it's common case, and you did it very well, as usual.
Thank
Yeah,
you.
so let's start from the beginning. Onset consideration. The side again, I just show you the picture, but you should ask me which side. And you ask either both side, and I will volunteer for the right side. Okay.
Yeah.
Start from you got that this patient is diabetic, so you can start a system review and the related complication in it, like CNS and the eye examination. You can ask immediately about the eye. However, you ask it in the examination, but I wanted to hear it earlier for the retinopathy and stroke, as you asked, stroke or mini stroke, you asked as well, and pins and needles, which was there in this patient, so peripheral neuropathy. Just to be systematic, not to in order not to miss any organ. Endocrine, you ask the cardiovascular, you asked about chest pain, and he had a history of heart attack, and you asked this well about what happened, but you didn't ask me what the surgery. This is very important in the surgical history. It might be cabbage, it might be coronary angiogram. So better to ask about it because he's uncontrolled, and this is one of the major vasculopathy affliction. The chest short of breath, you rolled out GI. Yeah, the GI containing a lot of complication. gastropathy, as you said, feeling full, early with the food, the bowel motion change, diarrhea, alternating diarrhea and constipation. You cover this one. Skin, you ask for the ulcers, the joint, and our patient is having joint, but the system, the only system you miss is the, sorry, sexual. This patient will have impotence because of, again, neuropathy, autonomic neuropathy. So he has partner. At the same time, you can ask how you have any problem with your intimacy, and it will be there. So this is the only system you miss in this patient. Family history, you ask, he has a history of stroke and his father, travel, no need, medication, and medical history, you ask allergy, surgery. The miss only surgery, but you ask for allergy, for medication, over counter. Sorry, the GI, you ask for actually for GI, sorry, genitourinary, frothy urine. And it's not nephrotic syndrome, by the way, it's only nephropathy. Okay, it's nephropathy, no need to mention nephrotic syndrome. It's complication of nephropathy. HIV for recreational and so on. Fever, you ask to roll out septic arthritis. The weight, you ask. So still you are systematic and organized manner. And this is very great. Your
تلميذتك يا
professional,
باشا.
yeah. Yeah, the occupation, yeah, yes, you ask for the job, the smoking,
No, I said
the alcohol.
تلميذتك والله. You taught me how to be organized لأنه دايما I was very
Thank you.
unorganized في البداية. Thank you so
Thank
much.
you. Thank you. But you missed the driving. You missed the driving
I
here.
did, yes, very
Yeah.
important. Oh my God, yeah.
Always ask these four together. Make it the
Yeah.
occupational together. Yeah, the job, the smoking, the driving, the alcohol and driving. Because he will
Okay.
have difficulty driving while his feet is not feeling any sensation. He might have an accident, and as well as the retinopathy. This is uh, the most important in this patient. You can advise him to stop driving for the retinopathy issue and for peripheral neuropathy issue. The examination, you did it great. You started by the complaint, which is the joint, the swelling. You asked for DVT. Excellent. It's very important because if he's immobilized, he might have DVT. I like when you ask about the circumference of the calf muscle. CNS, you did the eye, the heart examination for I mean, complication of cabbage or heart failure due to uncontrolled diabetes as well, in the form of coronary vascular disease. Okay, the differential, as you mentioned, Charcot joint, you said I might think about it's definitely it's Charcot joint. Swelling with the distended joint, and there is dislocation, multiple disorganization of the bone, destruction and deformity. All this going with
طب
Charcot
I
joint.
thought that the Charcot joint can be reversible. Like you can, if you try to put the joint together, it should go back together, I think.
No. It's
Or
deformed, totally deformed because of multiple fractures and multiple trauma. This is a precipitating factor, and he's not feeling anymore. That's why he's hitting and he's not feeling. That's why he has also ulcers in his left feet or in his foot in the big two sides. If you ask me, I will tell you. Yeah, you ask for to show, but I don't have picture actually for that. Yeah, so it's related to the neuropathy, and the multiple fracture make it worse and worse day after day, and fracture after fracture. It will never be reformed back unless there is intervention. Even the intervention, it will not be like the natural one. But you did it great. I like the differential for septic arthritis you should do because also it might be infected from any organism will might invade this wound and it might reach to the joint. Osteomyelitis as well, one of the differential in this patient. And you should do what you will do if this patient suspected osteomyelitis. Experiment.
X-ray, maybe MRI and antibiotics.
Yeah, MRI is the target investigation, so it will show you the osteomyelitis. And the opposite, you will find some hotness and tenderness in the same way. But why this patient is not in pain while he's having deformity? What do you think?
I'm sorry?
Why this patient is not in pain
Because of the neuropathy.
Excellent. Yeah, this is the okay. What other causes of peripheral neuropathy in this patient, if you think, for the history?
So other than the diabetes,
Yeah,
his vascular system seems to be rubbish, to be honest. I'm not sure whether it's because of the diabetes or he have
yeah.
problem, that's why he's having a heart attack. But
Okay,
also it could be the dietitian, because he feels full, maybe vitamin B12 deficiency.
excellent. Might be yes. Yeah,
Mm,
the absorption also it might be affected. Bacterial
yeah.
overgrowth syndrome because of the immune deficiency. And what else in the occupational patient taking alcohol? So it's also
But
and
he drinks
precipitate.
5 units only, right? Or
Yeah,
how much?
but you could put it, yes, even for the
Yeah.
long term, he might have also alcoholic along with the diabetes. So you can put it as a cause of peripheral neuropathy. That's it. Okay, thank you, Dr. Rinaz. Nice presentation and nice history and examination and well performance. So let's have the comments. You have any question, Dr. Rinaz? We're moving. Yes, okay. The chat, Dr. Awatif said no, not always reversible. Yeah, especially if deformed. Yes, because it might be like it might be fixed in the normal position because not all of them underwent surgery, so it might be deformed again and again after fracture after fracture. Any question? Any comment? So it seems the case very clear. Any question, Dr. Hind? Yes.
بس تعليق بسيط لما كنت عم بسمع
Yes, sure.
الماس
Welcome, Dr. Hind, first.
أهلا وسهلا فيك على كل بس السي تي لما قالت سي تي انجيو أنا بتخيل this
Yeah,
is very advanced very advanced.
yeah,
نحن بالعادة بيكون في عنا vascular injury أو suspicion of
yeah.
any arterial insufficiency فبنطلب الانكل brachial plexus ankle brachial مو plexus ankle brachial
Index.
index ثواني
Yes,
API تمام
yes,
الانكل brachial index pressure ankle brachial pressure index تمام مو
yeah,
plexus تمام فانكل brachial pressure index وبنطلب كمان الالتراساوند
yes.
ultrasound venogram ultrasound arteriogram
I
this
agree.
is we can
Yeah,
escalate according للvascular advice whether we need CT angio أو angiography تمام
mm,
this is usually the sequence of investigation.
But
yeah, I agree.
if you don't have pulse, usually we will need to start with a CTA. Maybe I think because one of the legs didn't have pulse at all. Because CTA you will need to involve the vascular surgeons right away.
طيب بس
Yeah,
أنت until you will have the vascular surgeon you are not the one who will order CTA it is them صح؟
They
yeah.
won't come and
I
see
will
the
tell you,
patient unless you do it. But yeah.
Dr. Rimaz, I will tell you,
تمام
they are assessing first the patient. Why you are avoiding this CT aortogram or arteriogram, Dr. Rimaz? You think about this patient. You might think about the complication from this procedure.
كونتراست وأعتقد بيكونوا عندهم
Excellent.
أنت
Yeah,
حطيتوها أي renal ف it will be a high
yeah, yeah.
risk procedure
Yes, excellent.
breast image فيعني
Yeah,
I
he will.
feel it is a big jump يعني you can mention that later we can escalate but start with the ultrasound و don't forget إنه sometimes we don't feel the pulse but it don't mean critical ischemia يعني
Yes,
it's
you're right.
us who fail to feel the pulse but it don't mean that there is a critical limb ischemia but it is something to consider I agree ف just يعني go in stepwise.
Step by step. Yeah, I agree with Dr. Hind, especially if the patient has the nephropathy, if the patient might develop CIN, contrast-induced nephropathy, and he might be in dialysis because of this contrast. While we can do diagnosis by duplex or this bedside Doppler, we can do. They are searching for either there is collaterals or occlusion, total occlusion of this vessel. So we can do color duplex. There is what's called color duplex. It can be the first step. Then we can advance to CT
escalate
aortogram.
to angio. You are right. والnerve
Yeah,
conduction
according to the
study,
need.
it don't need يعني I think nerve conduction study is part of investigation. Whether يعني recommended by neuro or by diabetologist ولا podiatrist,
Yeah.
all of them in any patient with peripheral neuropathy وهي start to have numbness, tingling, complication, يعني go for nerve conduction study والultrasound doppler والankle brachial pressure index هيك يعني as a first step. whoever you are يعني GP, diabetologist, endocrinologist، لأنه هدول فعلا الانيشال investigation. you
Yes.
can do them. والشاركوت جوين أنا ما بعرف الكيس تبعكم كانت شاركوت ولا بس peripheral
Yes.
neuropathy؟
Yeah, Charcot with peripheral nerve.
تمام. في الشاركوت بس ننتبه، أنا كأنه سمعتك ريماس عم بتقولي إنه it can be reversible if we يعني examine a joint it can be reversed. الشاركوت joint you will lose the case if you touch the joint. بتبعدي عنه نهائي، حتى ما بتقربي منه أبدا. يعني حتى
You might cause fracture by your hands.
يعني حتى إذا كان في عنا البروبريوسبشن، نحن إذا بتتذكروا بالبروبريوسبشن بنحرك الإصبع الكبير وبنحرك الأنكل مشان نقول له is it up is it down. فوي don't do it. وقت بنعمل السنسوري اكزامينيشن يفضل ما نعمل البين بريك ببيشنت عنده شاركوت، لأنه he will not feel، فأنت you might injure him. فبنعمل اللايت تاتش. تمام. البين بريك we do it whenever we are expecting the patient to tell me I can feel it. فأنا I know the amount of stimulus I should apply. فيفضل بالبيشنت تبع الشاركوت we avoid two things. We avoid the proprioception, we do instead the vibration. We avoid the bend break, we do instead the light touch. تمام. فهي يعني it's a welfare points بالشاركوت joint. we try to avoid touching it. وأغلب الأحيان بيكون البيشنت جاي وعلى رجله في bandage to hide the deformity. So always tell the examiner that I would like to remove the bandage. I would like to inspect the leg. حتى قبل ما تبدأ، لأنه ممكن تكون كل الكيس مخباية تحت الباندج و you don't know it's Charcot joint وجايك بأنكل swelling وunilateral يعني you will see deformity by your eye. remove the bandage. Try to avoid touching the joint. Be careful when you examine the sensory examination to pick the right modality. وبيحبوا يسمعوا ال offloading cast. ما بعرف أنا ما سمعتكم جبتوا سيرته.
No.
This is very important in any Charcot joint. It's called a special type of cast called offloading cast. فهو total rest of the joint by using a type of cast called offloading cast. تمام. في منها fixed.
If you can write it. Yeah.
في منها بيكون fixed وفي منها بيكون يعني movable. بيشلحها يعني بيشيلها من اجره وبياخد رست حتى ما يكون، لانه هدول السكين تبعهم دراي ولايبل فور كراكس. if you apply fixed cast وفي sweating you have to يعني it cannot be removed and يعني reapplied it can damage them. بالذات اغلب الاحيان الشاركوت يتزامن مع ألسر فبيكون صعب انك to apply a fixed one. ففي offload cast اللي هي removable. you teach him to apply وهي remove it check the skin ويعني بيعمل skin care وبيرجع بيحطها مرة تانية. بس المهم هذا الشيء والoffloading إنك تذكر اسمها mandatory. اسمها offloading cast. offloading cast. positive negative bisphosphonate لأنه البسفوسفونات can help in the healing. طيب الأوفلودينج كاست يتراوح الابليكيشن تبعها من 3 شهور up to 6 months with regular exchange if there is concurrent ulcer. ولو في ulcer واجب علينا نذكر tissue viability nurse لأنه she is the one who will take care of the ulcer. تمام. والبودياترست له علاقة بالأوفلودينج كاست. تمام؟
Yeah.
فلازم نذكر البودياترست، لازم تنذكر التشو viability nurse، نذكر
Orthosis.
الأوفلودينج كاست for 3 to 6 months according للstage of the Charcot joint، لأن الشاركوت joint stages، فكل ما كان advanced stage كل ما كنت بحاجة الأوفلودينج كاست for a longer period. تمام؟ finally surgical treatment أو surgical اللي هن
Correction.
الأورثوبيدكس if there is no improvement بالكونديشن. طبعا التوب ديفرنشال وهذا حضرتك ذكرته اللي هو الأوستيومايلايتس، ولا ننسى إنه الأوستيومايلايتس بالدايابيتس ما بتجي بهوتنس وبين كل هالكلام. تمام؟ because they are diabetic patient immunocompromised. So it's always a differential to exclude even if the inflammatory signs are not there. Okay? But if it is there, it's supportive. If it is not there, it's not excluding osteomyelitis. So we have to do MRI, we have to do septic screen. تمام? Especially acute onset. هلا لو chronic بيقلل من احتمالية الاوستيومايلايتس. والله من امتى عندك الديفورميتي والسويلينج هاد؟ والله عندي من 3 شهور. صعب هيك يقول الاوستيومايلايتس. تمام؟ it is less likely إذا كان chronic course. But it is always a differential to exclude. طبعا لو كان chronic ما حتحتاج MRI. ليش؟
X-ray will show it.
لأنه الأوستيومايلايتس حيبان لك بالإكس راي. هو الفيرست 3 ويك بتذكر اللي كان فيها الأوستيومايلايتس لا يظهر إلا بالMRI. لكن إذا عندك أنت ال duration of swelling is more than this، يعني ما له acute ما له 2-3 weeks، الإكس راي حيقول لك لو في حتى أوستيومايلايتس. تمام؟
Yeah.
لكن لو لاحظت الإكزامينر عم يسأل معناته ممكن يكون بده يسمع الMRI حتى لو كانت كرونيك قل له إياها. يعني it's worth mentioning it because it's a common question. تمام؟
Yeah.
If the examiner start asking what else in the investigation, tell him I might consider MRI if I want to exclude osteomyelitis. يكون عم بدور عليها. لكن مثل ما اتفقنا chronic less likely to be osteomyelitis. It will be apparent in the X-ray. اتفقنا؟
Yes.
فيش
Thank you. Thank you.
فقط غير المانجمنت والانفستيجيشن والارتيريال، يعني هدول أهم شيء.
Okay. Thank you, Dr. Hind, for golden advice and gracious one. Let's read from the chat box. What was the second joint condition seen in diabetes that Dr. Rinaz mentioned? I couldn't hear well. Dr. Rinaz, can you repeat what you mentioned? I'm not sure what you mentioned. The second question by Dr. Mahmoud does need to empower reflexes to exclude motor neuropathy. I don't think it's targeted for the sensation and the bone, sorry, and the joint. So I need to go
بس
for full power
دكتور
reflex.
باسم
Yes.
it's worth offering it. I agree.
Yeah, only to
لكن
offer.
we don't
Yeah.
do it. بس لأنه الدايابيتس is the cause of mixed sensory motor.
Yeah.
it worth offering الموتر، لكن الأولوية إذا ما في weakness بالهيستوري
Sensation.
بس في
Yeah.
numbness وtingling. تمام؟ I agree.
Mm.
بالذات
Yes,
إنه
yes.
الشاركوت joint، يعني أولاً أنت في عندك شاركوت you cannot examine الموتر لأنه ما فيك تقرب على الجوينت. هي أول شغلة حتخليك to offer it not to do it. السكند why you have to offer it لأنه الشاركوت is an advanced stage of peripheral neuropathy. فعلى الأغلب انضربوا الاثنين الموتور والسنسوري. It's not an early changes. أنت بالearly stages بيجيك بس سنسوري، واللي بيجي بس سنسوري ونمنس وتنجلينج ما بيكون عنده شاركوت لسه. صح ولا لا؟ يعني
Yes.
عندنا البيشنتس early بس عنده sensory neuropathy صعب شوف فيه الشاركوت. الشاركوت ما بشوفه غير تكون advanced 10 12 15 year خلص، وهذا على الأغلب بيكون في عنده combined. تمام؟ عنده sensory motor. فوجود الشاركوت بيعطيك كلو إنه it is more advanced. بس بنفس الوقت بسبب الشاركوت you don't want to touch الجوينت you can skip الموتر. you have to offer it. اتفقنا؟ يعني don't do it بس offer it. offer الموتر examination.
Yes. Okay, Dr. Naz, are you there? Dr. Naz? Dr. Naz, can you give me the case for the second scenario? Sorry for the delay. I messaged Dr. Naz waiting for her reply.
Oh, sorry. Hello.
Yeah, Dr. Naz, give me the case, please.
Yeah, I'm so sorry. Okay.
Okay.
So you have a 45 years old presented with leg pain.
Male or female?
Yeah. So sorry.
It's okay, male or female?
Female.
Female,
Her
so
name
I see.
is Lisa.
Lisa, yes.
Yeah.
1 minute only, then we'll
Your turn.
Okay, Dr. Naz, let's start.
Hello. Yeah, you can start.
Sorry. Hello there. This is Dr. Mukhtar, the doctor in the clinic today. You must be Mrs. Lisa.
Yes, I
You're,
am. Yeah.
you're 45 years.
Yes, I am.
So we are here to discuss about your health condition. Is that okay for you?
Yeah, doctor. Sure.
Tell me about this leg pain.
Well, doctor, to be honest, I had this pain for 2 weeks now,
Okay.
but now it's getting it's getting worse.
Is it the first time in your life?
It's the first time that I have pain, that much pain, yes.
But was it before the same previous attack or
No, I've
no
never had
previous
it,
attack?
no.
Okay. And you notice it's worsening.
It is, doctor, yes. It's the worst pain I've ever had.
So sorry to hear that, Miss Lisa. You have pain right now.
Yes, I do, yeah.
So if I give you a scale from 0 to 10, the 0 is no pain and 10 is the maximum, how can you scale your pain?
It can be 10, to be honest.
Oh, I'm so sorry. I can offer you a painkiller. Okay, that's okay for you.
Yeah. Thank you, doctor. They gave me some morphine.
Okay. So Miss Lisa, do you notice something worse than this pain?
I'm sorry?
Do you notice something worse, the pain? Make it worse.
Yes, movement. Any movement I do at all just make it so much worse.
Okay, anything make it better.
Anything that makes it better. It doesn't
Yeah,
go away. No, nothing makes it better, no.
even with the rest.
On rest, it doesn't get worse, but it doesn't get better. It's just there.
Yeah, okay. Okay. And with painkiller, you feel it better.
I tried paracetamol, doctor. I tried ibuprofen, codeine, everything. Nothing is actually working on this pain.
Sorry for that. This pain is traveling somewhere, going up.
It goes down to my legs sometimes.
So where exactly this pain? In the middle, and the and lower part, or the
No,
upper part of your leg?
it started in my back first, and now it's just like going to my legs.
So sorry that about that. Okay. Can you tell me more about this back pain? Is it
Yeah, so I had this back pain 10 days ago, and it's just killing me, doctor.
any trauma to this back area?
No, not really.
Did you lift any heavy object?
Heavy object, no.
Okay. And did you move suddenly? And you feel this pain after that?
Um, I don't know if maybe it's the case. I don't really know.
Okay. If I give you a scale of the pain from 0 to 10 about this back pain, how can you scale your pain in the back?
I think it's worse than my legs.
I'm sorry again. Okay. And Miss Lisa, any family history of same condition?
No.
Do you have any fever recently or before?
Um, yes, I have fever. I had the temperature. My temperature was 39
And did you notice it is all over the day or over the day or over the night?
all over the day for the past 10 days now.
Any lumps or bumps in your body?
Lumps or bumps? No, I don't think so. No.
How is your appetite?
Well, even if I wanted to eat something, doctor, I can't move to make myself something. I can't even use the toilet. I'm so ashamed.
Sorry about that. And do you have any change of your weight recently?
Well, I think maybe I've lost maybe a couple of kilograms over the last 10 days because I don't really eat anything.
Any night sweat?
No, just the fever. Very hot fever.
As I'm so sorry. I will ask you a sensitive question. Did you lose your control over the water work or the back passage?
Oh, that's very embarrassing, doctor. Yes, I think I'm starting to lose some.
Do you feel some pins and needles in your legs?
Yes.
Any weakness there?
I'm sorry?
Weak? Do you feel your leg being weak?
Um, yes, they are weak. I think maybe they're weak because I can't move, or maybe they're weak because I'm paralyzed. I don't know, doctor.
Okay, both legs or one leg?
Both,
Both,
but the
okay.
left is more.
Okay. Uh, any headache, Mrs. Lida, in your life?
Any what? I'm sorry?
Headache. Any headache?
No.
Any change of your vision?
Um, no.
Any chest pain or any chest pain?
No.
Any feeling of heartbeat or awareness of your heartbeat?
No.
Any weather preferences?
No.
Any short of breath?
No.
Any feeling sick?
No.
Any throwing up?
No.
Any change of your bowel habit?
No, doctor.
Do you notice you have recently infection anywhere in your body?
What do you mean, doctor?
I mean, an infection in your waterwork system. You had a recent infection.
No.
Okay. Any skin changes?
No.
Any joint pain apart from in your leg? You have joint pain?
No. I don't have leg joint pain in my leg. It's just all over
Only
me. Yeah.
all over there. Okay. You feel this pain in your leg like electric like shock?
Sometimes, yes, doctor.
Okay. Any travel history recently?
No, I haven't been
Any long
anywhere.
lasting? Okay. Any long lasting disease I should be aware.
I just have osteoporosis.
Okay. What you take for this?
I take alendronate.
Did you investigate about this osteoporosis?
No, my GP think it's because of my steroid. Because I used to take a lot of steroid,
Why you are
but not
taking
anymore.
steroids?
I just had a condition.
Can I tell me more about this condition?
It was a skin condition.
Yeah, like infection or
No,
do
the
you know
doctor
the
said
name?
it's just I think maybe pemphigus vulgaris or something.
Okay, so you don't have skin change right now.
No.
Okay, and are you compliant to the steroid and the medication for osteoporosis?
I cured and they stopped. They weaned me down. I used to take 10 tablets and then 8 and then 5 and then 6 until I
And they stop.
one and then I stopped them. Yeah, 3 weeks
Okay,
ago,
and
4 weeks.
for the medication of osteoporosis, you are taking compliant. You are adherent to the
Yes,
medication.
yes.
You are exposed well to the sun.
I try my best, but since I have been unwell, no.
Okay, you have partner.
No, I live alone, doctor.
Okay, you have any casual relationships? Sorry for this question.
No.
Okay, any problem with your intimacy?
Do you
You
mean
notice?
now?
Yeah, or before? Yeah, recently.
I don't think about intimacy now. I'm in so much pain, doctor. What do you mean?
I'm so sorry. Yeah, I'm so sorry for this, but I'm asking this question to all my patients. What's your job, Mrs. Lisa?
I'm a teacher.
Okay, and how that affecting your job?
I couldn't go to work for the past 2 weeks.
Sorry for that. I can provide you with the sick leave to help you.
Yeah, I
But
will
Miss,
need it. Yeah.
yeah, sure. Sorry for this question, Miss Lisa. What's about your period? Still you have period?
Yes.
Okay, is it
Um,
regular or it changed?
okay.
Any
No,
change?
no.
Okay. Tell me if you smoke ever.
No, I don't smoke.
Do you drink alcohol? Or did you drink alcohol ever?
I drink just socially.
Okay. Do you drive?
I do, but not anymore.
Okay. This is great for your safety. So, Mrs. I will examine you and I might ask you further question while examining. I will start by the general look and vital charts,
Okay.
temperature, how the temperature,
Um, 35, 38.5.
okay, and blood pressure,
100 over 55.
blood sugar,
Normal. Normal.
any surgery before, Mrs. Lisa,
No,
any allergy to any medication,
no,
Okay, so blood sugar, I asked the vitals. Okay, I will go direct to the leg. Where is exactly the pain? I will examine for the skin around the pain, any change of the sensation.
The legs are normal, just the weakness, the inspection is normal.
Okay, no skin rash around, no deformity, no hotness, no redness.
No.
Okay, I can ask now for the CNS examination of the legs, both legs, tone, how the tone,
When in the progress.
the tone.
Okay, I'm sorry. The tone is low, hypo.
Okay, the power,
Um, uh, 3 and
both,
and 2 to 3.
both in both legs, right?
Yes.
The reflexes,
Hypo.
even with exaggeration. I can ask him for clenching, still hypo.
Yes.
Okay. Now I will examine the sensation modality in both legs. Then change.
I'm sorry. Say that again.
The sensation, modality
Mm.
sensation. I mean fine prick and pin prick, fine touch and pin prick.
So tell me where are you examining, and I will tell you what's the modality.
Yeah, I will start from up down. If he feel
Normal.
normal, no change. So pin prick, any hyperreflexia
No, but you're
by
going
pin prick,
from up down or from down up? Where exactly? Just tell
down
me where
up,
you're examining.
down up. Okay, but down
Mhm.
up.
Okay, so you're
How
at
is
the
it?
ankles, normal feelings. Uh-huh.
Okay. No, the pinprick, is it hyperphagia?
You don't get me. So tell me where are you doing the pinprick? In the leg, in the
Both,
toes, in
yeah,
the knees, in the thigh?
in the legs, bilaterally comparing both sides from
No
the lateral side,
abnormality.
medial side, and
No
from the leg
abnormality.
side also. So he's not
Normal.
feeling hyperphagia or
No, not in
electric
the
pain.
area. No.
Okay, joint position, vibration.
Normal.
Okay, no skin changes all over the body, in the mouth.
Um, no skin
Okay,
change.
let me examine the back. Quick
Okay.
examination of the back. Any scar there,
No scars.
but there is pain.
There is pain and tenderness. Yes.
Tenderness. He can't move. She can't move because of this pain. So
The
let me know
patient
what's your
can't move.
concern.
No.
Yeah,
What's
let me
going on,
know.
doctor? What's going on with me?
Yeah, I appreciate your concern. What from the history I took and the examination, Miss Lisa, you might have a fracture in your bone in the back, and this fracture might also injure the nerve supply and the nerve cable supplying your legs.
Mm.
So I gonna admit you to run some investigation to confirm my diagnosis and to roll out other possible diagnosis. And I might call some group of specialists to manage you according to the need. And you might need a surgery to your back. Is that okay?
Okay, doctor. But doctor, why do I
Yeah.
have fever and why is my heart
Because
beating
of
so?
the so fast. Oh my God.
Yeah.
Time is up.
What's your
Again, the
differential?
question. Again, this question. Let's.
Why is my heart beating so fast?
I asked you if you have heart racing. You denied that.
Did I? Oh my God, I'm sorry. It's my fault then.
Yeah,
Sorry.
it's
I'm
okay.
so sorry.
It's okay.
Heart rate is
Okay.
115.
Oh my God. Okay, this is due to pain. Okay, let's yeah, due to pain. Let's say that. Okay.
Let's say, okay,
Uh
what's your differential? What was the case about?
yeah,
Sorry.
yeah. Mrs. Lisa, 45 years, came with complaint of leg pain, and it's more in the left side. However, both sides there is pain, and it was started 2 weeks back, and it's worsened day after day. This pain started after uh, she had a history of back pain, and both pains are severe, 10 out of 10 in the severity. And I guess this is mechanical pain, maybe due to a history of osteoporosis. And it was because of steroid ingestion for a condition called pemphigus vulgaris. It's an autoimmune condition for the skin. By the history, I found that she has a history of fever, high-grade fever 39, some loss of weight, and appetite is reduced recently due to the might be the high-grade fever. Apart from this, there was heart awareness, maybe due to the pain and severe pain, family history and travel history, and HIV risk are not there. Patient is teacher and she cannot cope with her job. She's smoking and she's not smoker, drinking alcohol socially, and she stopped driving recently. Might be due to the condition.
Okay.
So my
How are you
differential,
going to manage this patient? Yeah. Oh, sorry. Put your differential.
yeah,
Sorry.
the differential osteoporotic fracture of vertebrae, and the second diagnosis, disc prolapse or spinal stenosis, or we can say what's the name? I forget the name. Okay, let's see the management, then I will be back to this
You mean
differential.
Codacoina or?
Yeah, Kodai syndrome.
Okay.
Oh my God,
Okay.
the one who the diagnosis and he's not remembering the name. Okay.
It's all right. So how are you treatment?
Yes, I
If
will
I say
I will,
treatment.
I will admit this patient because of the pain severity and features of maybe there is infection in the bone and the fever she has. I will first run some investigation, basic workup, CBC, inflammatory markers, ESR, CRP, for calcitonin, and the kidney function, liver function tests, and I could do calcium and parathyroid profile, calcium, phosphorus, magnesium, all electrolyte. Alkaline phosphatase as well I need to do. Then I will do some imaging starting by X-ray on the back. Even it might need MRI of the back to rule out fracture and nerve affection. Yeah, one of the differential discitis. Sorry, we didn't mention it. Okay. Okay. The
This is the
imaging I am done.
diagnosis. It's not one of the differential.
It's a diagnosis because of the fever. Yes, you're right.
Tachycardia and hypotension. She's actually
Yeah.
septic.
Yeah. Okay. You mentioned for me she's hypotensive.
Yeah, the blood pressure is
Okay.
100 over 55, I said.
Okay. Maybe she's hypertensive, you mean, and this is this heart rate blood pressure, I think, low for her, you mean?
Hypotensive and tachycardia, 100 over
Okay.
55. We have a heart
100,
rate
yeah. I
that's
heard
high.
it
We have
110.
fever.
Yeah.
Oh no,
Okay.
over
Yes,
55.
you're right. Yeah. Discitis. Yes, you're right. Okay. So I will go back to the management. Yes, I will call a multidisciplinary team approach, starting by orthopedic, neurology, and neurosurgery, orthopedic as well, and radiology, and infectious disease team, a GP, and specialized nurse. A physiotherapist as well might need, occupational therapist.
Why do you think you
Apart
need the
from
infectious
that,
disease team?
yeah, I will need them to first I will do blood culture to know what's the origin of this infection and what the source and what the organism. So I could start here by after opinion of infectious disease. I will start here on empirical antibiotics till the blood culture result release. I should cover all organism. I mean gram negative, gram positive, and might need anaerobic coverage.
Okay, your time's up. Okay, so I
Yes.
think you did very well. The most important part, Dr. Basim, is that you covered the red flags, which are leg pain, worsen movement. With if you ask her, she would say coughing and sneezing. I think she said that she can't move, she can't cope at home, and she have fever. She's septic. She needs to be admitted, and we need to do ABC. So the
Yeah.
sepsis. We need to stabilize her. She needs the IV fluids and um and antibiotics. And she might need oxygen. Who knows? She's hypotensive, and we will involve the neurosurgeons immediately. So the first team that needs to be on the ground is the
Yes.
neurosurgeons.
Yeah.
Immediately, the MRI just after the baseline bloods. Just she needs the MRI to be done now. uh, we we need the new surgeon to decide whether, do you think, guys, dexamethasone would be a good option now because we have an infection, but we still have a fracture as well. Um, and I believe you took a very good history. At the beginning, she didn't mention the back pain until you asked, which is sometimes patient might think that their back is hurting because of their legs, or that their legs is hurting because of their back. Um, and so I think you did well. Obviously the ABCDs are very important. So the first thing that you need to mention in the management plan is that acute
Yes.
management now need to
I,
be admitted, to just give us the sound of urgency.
yeah.
And also, so I wouldn't worry about the serum calcium now. I would worry about the MRI scan. I would also, there is something else. The TNO, I'm not sure whether they have anything to do here. The patient might be admitted under them, but just because she needs to be seen by the neurosurgeons. We'll involve
Yeah.
the neurology as well. The antibiotics, yeah, that's a very good thing. So you mentioned the antibiotics, and you said you will give her empirical antibiotics. What you should say is, I will give her antibiotics according to the trust guideline. The trust is the hospital that you work at. Every hospital have their own team that puts the list of antibiotics. So it's very easy. You just go to the intranet, open the computer in the hospital, and you will find every condition have certain types of antibiotics or certain lists that should start with.
Yeah.
And then
Right.
you can involve the microbiology team, not the infection, because the infectious disease team is the team that deal with meningococcal septicemia and everything. That's a very big international team that we don't need to involve now. We need to involve the microbiologist, which is the micro team. And they might help us with the antibiotics, but we would start according to the trust guidelines. What else? Um, so it's good that you missed discitis, but you still put it in the differential. You put it as the last thing in the differential. Um,
Yeah.
so this was a case in the mock test.
Mhm. Yeah.
Um,
Nice.
exactly. So the mock test that I had a patient, it was a doctor who was pretending to be a patient. She was 75, and the GP referred her because he think she had fracture because she can't move. She had fracture because she's not osteoporosis. She also had discitis, which can be provoked by the fracture. Um, and yeah, it was literally the same. From outside, you will see that she's hypotensive, she's tachycardic, and then she's febrile. Why does she have fever? And you start thinking discitis from outside before you go in and see the patient.
Yes.
And you excluded the primary or meds. Ask about weight loss and night sweating and everything. History of contact with the cough, just to a chronic cough or something, just to exclude POTS disease, tuberculosis,
But
yeah.
yeah. Yeah.
But otherwise, I think you did very well. It's just that sometimes you need to give us the sense of the urgency. لأنه أصلا the PACES exam
Yes.
invented to make sure that when the consultants go home, the registrar will cover the hospital, and he's gonna be
Safely.
safe. Exactly,
Yeah.
because this is what happens. Everyone will go home, and probably I'm 31. I would be the most senior medical doctor in the hospital, which is very, yeah, very huge responsibility. How do they make sure that I can do this? Is by doing the PACES exam. You just need to show that you're okay to deal with that.
Yes.
So it's okay to overdiagnose, but yeah, in this case, but yeah, I think very well
Yeah.
done.
The source of infection. Can you?
This is I
Yeah.
believe fracture precipitated for discitis.
So no invasion from outside, you mean?
No,
And plus, she's
not even.
immunocompromised on steroid,
No,
maybe.
she can be. She stopped the
Yeah.
steroids, she said, weeks ago, but she can be
Okay.
immunocompromised. Who knows?
Yeah.
She stopped the steroids, and because she had osteoporosis, and she got better basically.
Yeah. Okay. And the most common organism here is Staph aureus.
Yes.
Yeah, in this case. Okay. Okay, thanks, Dr. Inez. A nice case. So
Thank you
we
so
are
much.
in the same page of the disease. I mean, joint and musculoskeletal.
Yeah.
My,
Yes. This
okay,
was not the case that I wanted to give you, but when you
yeah,
mentioned the foot pain, I
yeah.
just
So you make it,
remembered it.
yeah, nice.
Yeah,
Yeah, yeah. Better to be in the same complaint and different
exactly.
differentiate.
Yeah,
Yeah.
yeah.
Thank
Thank
you
you
so
so much.
much. So, yeah, thank you. So both cases were mechanical pain or mechanical
Yeah.
joint pain or mechanical, yeah,
Musculoskeletal system, basically.
musculoskeletal system. Yeah,
Yeah.
basically. Thank
All
you.
right.
Thanks
Thank you
a
so
lot.
much.
Yeah.
Beautiful.
Okay, thank you. Okay, any question or any comments in the chat box? Dr. Rabia asked where fever came from. I mean, discitis, Brucella, TB, bacteria, or any procedure. Yeah, I think she answered this question. But still, you have to take history for TB by asking contact with sick people or just symptoms. Actually, and honestly, I did ask about recreational drugs and sharing needles. It's very important. This patient, it might be the reason of organism. Sorry, to be the reason of organism entrance to the body. So I guess also this is an important question. I missed. But anyway, I missed the diagnosis itself. I just did osteoporosis, disc collapse, and pudicina, and there was fever, so should think about this discitis. But thanks God I mentioned it at the end. So I hope Dr. Rinaz will give me the mark, full mark. Okay, any question, any comments?
Yeah, please.
Before-
Good
Yeah, sure,
evening.
Dr. Dalia. Welcome back. Good evening.
Uh,
Okay, here you are.
no, Sultan.
Yes, the
Okay.
best thing in the
Yes.
life ever.
Yes. Yeah, just a second.
Okay, sure. Take your time.
Yeah, I want to, I know it's everything in your mind, and even me, I'm not sure
Yes.
if I'm in the hot, in the
Yeah.
hot chair. What shall I do? Okay.
Yeah.
So I have just tips could help you. That's from the start. Ask about past medical history. It really could help you a lot, because from
Yes.
start, before I go ahead, if she knows that she is already has been a skin problem, and you got the name, and you know that she's on steroid, and the patient has leg pain. So from this point, you'll go straight, what's wrong with
Yes.
this leg pain? So
Yes.
you could catch the disease early, because if you know that this leg pain is called equina, and so this is very the emergency, top emergency.
Yeah.
So
Yes.
from that point, you just need to do general review, general question, as you did, but it's little bit late. So because you didn't catch the diagnosis early, so you dig about, you want to know why this patient has just fracture, and you already exclude the fracture, nothing lifting up, nothing, no heavy lifting, no sudden movement, no sudden. The problem is that, is it that out of sudden or gradual? I guess this question was critical here, to ask about the pain. Is it out of sudden, or not. Okay, so and after you know the symptoms of the rest of the symptoms of cold equine, you didn't ask since when. You know that there is this, all this is take long time. How it's progressed. So, for example, the loss of control and the rest, the weakness, I mean, and the weakness, okay? So I need to just to know when exactly it's deteriorated, because the patient might have pain, then after that it could be because the infection and later on. So when you count that the patient has high temperature on steroid, the neutropenic sepsis on the top, where is the source of infection? So you will ask the most common area, the UTI and pneumonia, the cough and the burning nutrition. So then after that, you ask about headache and neck stiffness to exclude meningitis, and so because this patient is septic. So I will see infective endocarditis, pneumonia, any bowel change, and you search quickly systemic review looking for the source of infection if there is any of them before that. Okay, and if you reach this point, you need to go quickly for other things, to examine the patient, and if you finish while you're examining the patient, just complete your history. That's the other part. Already you ask about past medical history and you've touched the drug history, so quickly you could do the rest of things. No need to tick all boxes that Irish candidate they do, because you don't have enough time for cases. So they need to be target history, very focused examination, target examination. So after you finish your this point, you will be in safe. You save yourself, because you took long time. I guess that is not enough for the steps of examination. And the last thing, that when she asked you about the clinical findings or present your case, you repeat the whole history. I guess it took around 2.5 minutes, if I'm not wrong. You took long time, even you are mention the past medical history, the drug history, every details. Already the examiner already hear that while you are asking. So you need to pick the most to reflect that you picked the most important positive history points, okay, and the finding points. Okay, that it shouldn't exceed around 40 seconds, 40 seconds, because you need 1 minute question and answer for differential diagnosis. You need 1 minute around question about his investigation, and you need to answer it, and you have to answer to be questioned first for the treatment, and you answer. So if you divide it, 4 minutes for presentation, differential investigation, then treatment. So if you took long time for the only around 2.5 minutes for the presentation, so you are put yourself in the skills of the clinical judgment. You put yourself in, that is not would help you to be assessed for investigation and management, So the bill will rank quickly. And so you will put yourself just only presenting your case about, you repeat you already what the examiner already got it from the history that you already asked the patient about it. I don't know. I don't know if I'm right or wrong, but this is my opinion.
Yeah,
Okay.
thank you. Yes, sorry. Yeah, I can say I'm intentionally doing that just to waste the time, not to ask me for further exam, I
Yeah.
mean, the investigation and treatment. I don't know, is it wise to do? Because
Yes, it
I would just
isn't
give
at
him.
all, by the way. This is I don't know who mentioned that. I've heard that early, during the journey of the paces, okay? But this is very wrong one, okay? They need to be quickly mentioned because you need to reflect that. For example, if the patient said, I have these symptoms since 3 months ago, and it's now it's going worse for the last 1 month, and it's if the patient said this all these together, you need to reflect that in a very professional way that this patient complained of chronic progressive leg pain. That's enough. He already heard that it's 3 months. He already heard that it's recently getting worse. Okay, so you just want to reflect all this story just in 2, 3, 5 words, or just 1, 2 sentence. That is chronic. This is a chronic progressive leg pain on a background of bifidus vulgaris on long-term high dose steroids. Okay, the patient has, for example, sepsis symptoms or signs. For example, the patient already has high temperature, shivering, and you have low blood pressure and high pulse rate. So if I just give summary for what you got, that usually what you do, and if you want to update the consultant about your case in the hospital, give just you know the the the
Yeah, the
the the,
conclusive
the
criteria, yeah, of the
conclusive,
case.
yeah, that if you are on
Yeah,
call and you just want to update the consultant about the patient, just did what you already do every
yes.
day.
Yeah, I
Okay,
agree with you,
so
Dr. Dalia. Yes.
this will reflect that you are very professional, that you
Yeah,
already what the
yeah.
consultant
I'm
want.
just touching the positive, yes.
Yes, try to just summarize what you got. This is chronic progressive pain on background of blah 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 and blah 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 and blah blah blah. And he has signs and symptoms, for example, of sepsis. It could be neutropenic sepsis because on high dose steroid for 6 months, for example, or for long time or something. This is now the message it's already. And he has signs and symptoms of coda equina. Okay, so and the patient, they need to be. I will approach the patient for the management for ABCD approach. Okay, and they would like for basis exam. If British examiner, they need to hear sepsis 6 because this is cover all what you want to measure and what you want to do. Okay, quickly, he will not ask you because when you said that, already all the steps is inside. Okay, then after that, go straight for, we'll take blood. Okay, we'll take our blood for, mention that blood culture, very important, and the other baseline, and look for the urine, chest x-ray, do that, a blood sugar, all the sepsis investigation. Okay, and you need to do MRI, okay, for the patient, and as Dr. Rimaz that to involve the neurosurgeon urgently. Okay, we will involve the neurosurgeon urgently, and usually the movement, it should be I need to safe net the patient not to move because I'm not sure there is fracture here if he moves, because usually in the hospital that if this kind of patient, they wouldn't try to move the patient because they need to be assessed by the neurosurgeon. He needs to look at the scan to see if it's stable fracture or stable, his vertebra is stable or no. So if he mentioned it's stable, he could move. He could, because you need to tell the patient to move, to exercise, physiotherapy, or whatever. So this assessment usually be done by the neurosurgeon. So be in the, because it might, you know, I don't know where the word, this might
Yeah,
affect the patient. Yeah,
yeah, I got it. Yeah,
it works.
for the
Yeah.
welfare. Yeah, for the welfare, don't
Yes,
examine him
yes,
by
because
yourself.
this is, yeah,
You
if
might
it's
harm him more. Yeah,
unstable
yeah, yeah.
fracture, and the
You might
patient move,
make it. Yeah,
yes, and I'm not sure, shall I do for examination for the all steps of power, or I'm not sure. In such case, if I see this patient has symptoms and signs of a
nerve
code
affection.
one.
Yeah, yeah,
Yes,
you're right.
and the last thing that you didn't ask, it's PACE is you know, trained is to ask a patient about when you wipe yourself. Do you feel this the when you wipe yourself? Do you feel the tissue paper or no? The toilet paper or no? Okay. If she said
Yeah,
yes, this is said
perianal
earlier.
anesthesia.
Yes,
Yeah,
yes, yeah. Perianal anesthesia. This is the last question for the
to rule
back
out.
pain. Yeah,
Yeah,
the code equine symptoms and signs.
Yes,
Okay.
by
yeah,
the way, that's why I was asking you, where do you want to test the sensation?
Yes,
Because
yes, I got you.
yeah, I was like,
yes,
where do you want to do it? Because if you said, if you just mentioned the thighs, I would know that you were looking for the saddle shape, the saddle numbness.
Yeah, inner thighs, upper inner thighs. So if it's just high up above the midline of the thighs, up inner thighs.
yes,
If you
yes.
don't want to touch
Saddle shape
the
area.
private area, yes.
Excellent. Yes.
Okay.
Thank you, Dr. Dalia. Thank
Okay,
you, Dr.
welcome.
Imaz, for explaining the point late. So
Thank
you
you so
want me
much.
to examine the saddle area? Okay, I got
Yes,
it now.
they can
It's
offer
okay.
it. Can offer it.
Yeah,
Yeah,
if you
at
ask
least,
it, okay.
yeah. Okay, so the difference between coda
else,
equina, yeah, Dr. Hind, sure.
لا continue. Different between code equine and what?
And the other syndrome, which is affecting
Conus,
also
conus medullaris.
conus medullaris. Yeah, I'm always forgetting the names. So the perianal and the saddle area affected in this coda equina or in the conus medullaris?
It's more in the coda equina because you're looking at a lower area. So
Mhm.
if it's lower, then it's gonna be covering the S, the sacral and the late lumbars, right? Unlike and we're looking at lower motor neuron lesions because it's all lower.
Yeah, it's lower, yes.
So exactly, but the conus medullaris, it might be mixed
It's
upper and
upper.
lower, and
Yeah.
blah.
Okay. Yeah, clear now. Thank you, Dr. Rimaz. Yes, Dr. Hind, your comment?
You ask about a question that what is the source for this discitis, صح? أول شيء
Yeah.
differential diagnosis I prefer whenever we have a mechanical back pain and fever. You have to mention 3 differential, top differential, mechanical plus fever, discitis, osteomyelitis, abscess.
Yes.
Okay. So, and all of those are risk factor in this patient or any diabetic or patient on steroid or elderly patient حتى. تمام. You are right إنه in your history you should look for the risk factor or the causes اللي هي either direct inoculation. You should ask about any recent procedure in the back. فرضاً lumbar puncture. This is the most common أو أي surgical intervention in the back أو أي surgical intervention elsewhere. في common scenario للدiscitis associated with a procedure. Anyone remember it? حنراجع السيناريو تبع الدiscitis because actually this is a very important
Pacemaker,
topic.
central line
حيطلع
pacemaker,
شو قلت؟ صح.
pacemaker and
pacemaker
line.
عليك نور.
Yes.
So you should ask about a procedure either at the back يعني local procedure أو حتى any kind of procedure. Even sometimes recent cannulation يعني حطوا له peripheral cannula. تمام. You have to ask about any recent procedure, intervention, cannulation, pacemaker, procedure in the back. You should look for any scar. تمام. لأن patients he might not consider it significant أو he might not tell. فأنت at least look a local inspection for a scar سواء بالباك أو while you are examining. بعدين after the direct inoculation أو procedure اللي هي دخلت البكتيريا directly على البلد you should look for any kind of infection starting from clear infections اللي هي ال upper respiratory tract infection, genitourinary tract infection, والwounds skin infection. تمام. starting from cellulitis up to open wound وulcer. لأنه all these are حتى pressure sore مثلا, all these are a source of entry. تمام. والهيدن هدول الأوبفيوس, هيقول لك أنا عندي cough, أنا عندي sputum, أنا عندي burning micturition, أنا عندي open wound. طب شو هن الهيدن؟ الدنتال infection, الانفكتيف endocarditis. تمام. ولو كان elderly patient unconscious confused, you should look for the bed sore وال pressure sore, لأنه he will not complain of it. بس لو هو patient normal mobile, the third point is not significant. أهم شيء الدنتال والinfective endocarditis. تمام. ف those are we forget them always. وحتى بما إنه هذا البيشنت اللي عندنا كان عنده tachycardia وhypotension, فالinfective endocarditis is very important. Whenever we have a pathology from Staph aureus, الإيكو is very important to be mentioned in the investigation. تمام. It's always a differential diagnosis as a primary source, أو بسبب إنه الستاف أوريوس بالدم, فأكيد هي ممكن تأذي الديسك, ممكن تأذي الهارت. I have to take care. Plus, when you examine, you should examine the mouth looking for any bad dental hygiene or recent dental workup. Okay? This is regarding the direct inoculation, hematogenous spread from clear infection or hidden infection. Third point, you might screen for all of those you don't find. عادي. This is also a possibility in any case of discitis and osteomyelitis in the back. تمام. أحيانا بيكون في عندهم graft, في عندهم prosthesis بتخليهم at risk of discitis. هي كمان rare. فالpacemaker was a common scenario. في second scenario كان recent أو incomplete treatment of wound. كان عنده wound وما أخذ الكورس كامل تبع الانتيبيوتيك, فمشان هيك أنت لما بتسأله بتقول له any wound بيقول لك ما في, لأنه الwound healed أصلاً. تمام. when you ask him any recent course of antibiotic يقول لك yes. تمام. وهي واحدة من الكيسز بالRCB samples. تمام. take care of those questions, any recent antibiotic, any recent wound, any recent procedure pacemaker. هدول الموست common. وجود الأوستيوبروسيس بالسيناريو, تمام, له مغزى. لما بصير في عندك بكتيريميا بhealthy person without osteoporosis أو without pathological fracture, صعب إنه البكتيريا تعلق بالvertebral column وتعمل contiguous infection للديسك. طبعا هون لما بيكون في عندي osteoporosis, البرايمري infection بصير بالبودي of the vertebra, بعدين بينتقل على الديسكايتس, ما بيكون بالديسك وبعدين vertebra, لأنه بيقول لك الباثولوجيكال أو السيك vertebral body form something called nidus, يعني بؤرة صالحة لأنه تنمو فيها البكتيريا للنمو. تمام. فوجود الأوستيوبروسيس in any scenario or osteoporotic or pathological fracture is only a clue that this vertebral column is more prone whenever there is bacteremia, تمام, for bacterial infection. فالبكتيريا حتلاقي فيه good environment to stick and to start to grow, وبعدين حتعمل contagious infection للديسك. This is the idea of the steroid and steroid precipitated osteoporosis, and this patient might have osteoporosis or osteoporotic fracture, and on top of this بدأ يصير عندك discitis. وضحت الصورة؟
Yes, clear
Okay.
now.
Dexamethasone, don't mention it whenever you have discitis,
Yeah.
because with infections, it's very risky to give steroid. First we have, usually if it is a cancer, تمام, اللي هي الكارسينوجينيك إديما. تمام. والكارسينوجينيك إديما usually is an acute issue. okay. وما بيكون في قبل منها, يعني suddenly the patient will have وحتى أحيانا ما بيكون في عندك فيفر إلا إذا كان بقى الفيفر اللي associated مع الconstitutional symptom تبع أي كانسر. فتيك كير إذا أنت عندك signs of infection when you mention steroid، أو حتى لو بدك تقول steroid لأنك أنت خايف إنه يكون في عندك كانسر أو carcinogenic edema، you will say dexamethasone after exclusion of infection. You are safe like this. خلاص أوكي أنا I might need dexa تمام because there is a compression symptoms but after exclusion of infection. تمام like this you are safe. But never mention dexa alone and you have fever and there is a possibility of infection. تمام. يعني this is an important thing.
اوكي دكتور.
شو كمان كنت
Yes.
بدي أقول على شغلة؟ لا differential diagnosis we mentioned them واتفقنا الإيكو. Did you mention الإيكو in the investigation?
No,
It is very
they're very important for infective
full septic
endocarditis. Yes.
screening ولازم to screen for all infections. أنت صحيح ما لقيت symptom، هي أول خطوة history
But
wise.
still,
infection
but still
فلازم
I
تطلب urine
can.
analysis, urine culture,
Yes.
chest x-ray, sputum cultures, inflammatory
Blood
markers،
Yeah.
كل السكرين مع الإيكو والإي سي جي.
Blood culture is most important. Yes.
blood cultures
Yeah. Okay.
طيب سألت على الكودا إكواينا والكونس ميدلاريس السنسوري صح؟
I asked for the sensation in the lower limb, but I miss the difference between. But Dr. Rimaz mentioned it.
تمام. ولا
But
تنسى إنه هذا
I
البيشنت
asked.
حيحتاج urinary catheter insertion. فيك تقولها
Yeah.
بقى بالمانجمنت، فيك تقولها يعني anywhere you want، بس he need with this incontinence لأنه they are liable for incontinence و retention، يعني any of them according للinjury.
Yes.
تمام.
Thank you, Dr. Hind. Yeah. Okay, great. Always we are receiving golden advice by Dr. Hind and Dr. Dalia. Thank you all.
وشغلة
And
تانية
always
بس بدي
attend
أقول لك
with us.
عليها بس قبل ما
Yes.
أنسى، السنسوري
Yeah.
برزنتيشن تبع الكونس ميدولاريس حصرا بالبيريانال اريا. تمام. لأنه الكونس ميدولاريس is part of the spinal cord، مسؤول فقط على البيريانال. بس وقت بيكون عندك كودا إكواينا، الكودا إكواينا is multiple nerve fiber نازلة من بعد ال L1 وال L2، من بعد ما انتهى السباينال كورد. تمام. فممكن تلاقي فيها حتى مثلا distribution بالاس 1 اللي هو بالليتل فينجر. متخيل معي الفايبرز اللي نازله بالكودا
Yes.
إكواينا ما بتغطي بس الصدر اريا، بتغطي من L2 للاس لاخر الاس اللي هي الاس كم
Yes.
1 2
S5.
3 4 5
S5.
تمام.
Yes. 5. Yes.
تلاقي الصدر بلس من L3 على حسب مين الفايبرز يلي مضروبة بالكودا إكواين. فما بتلاقيه بس صدر الاريا. مشان هيك انت بتقلك which part you want to examine في الصدر plus dermatomal distribution، مو peripheral neuropathy distribution. فبتمسك dermatom. لو لقيت أي dermatom plus الصدر area which you cannot examine ف this is more likely coda equina. أما لو لقيت ما في ولا أي sensory معناتها مين؟ كونس ميدولاريس، لأنك أنت الوحيد اللي ما قدرت تعمل له examination الصدر area. تمام. صعب إنه الكودا إكواينا تمسك لك بس الصدر area، لأنه أنت وقت حتعمل compression على كل الفايبرز اللي نازلة، صح؟ مو بس حتمسك الفايبر اللي نازلة من منطقة الإس، مو مثل الكونس ميدولاريس. تمام. فأغلب الأحيان بالكودا إكواينا في أكثر من sensory loss. الوحيد اللي بيجي isolated صدر هو الكونس ميدولاريس. تمام. اوكي. وحتى ترى الكونس ميدولاريس حواليه مين؟ حواليه فايبرز نازله من ال، يعني اخر فايبرز نازله من ال كمان موجوده حواليه. فالكompression على يعني الكونس ميدولاريس لو very small to compress الكونس بس صدر الاريا، وهذا وقتها بنسميه كونس ميدولاريس سيندروم. لو كان الكompression is very big و affecting larger area ممكن بقى يبدا to compress على الروتس يلي نازله من ال upper part of the spinal cord. تمام. حتى لو شفتوا الاناتومي حتقدر تستوعب معي الكلام اكثر. بس بشكل عام كونس ميدولاريس سيندروم بيريانال. الكودا إكواينا is more صدر plus dermatomal affection.
more broad affection. Yes. Okay. Thank you, Dr. Hind. Yeah, thank you. Okay, in the chat box, any question? Okay, Dr. Rabia will answer your question. Dr. Amin shared, yeah, the difference between CODA and CONUS middle is very important. Yes. So the CONUS, let's read it quick. Presentation of CONUS will be sudden and bilateral. CODA equina will be gradual and maybe unilateral. The knee jerk preserved, ankle jerk affected in the CONUS. In the CODA, knee and ankle affected. CONUS will be less severe, the severity more in the CODA equina. Okay, the sensory numbness often localized to perianal area, as Dr. Hind mentioned. This dissociation can occur, usually bilateral and symmetrical. And the coda equina numbness often localized to the saddle area, maybe asymmetric, and unilateral sensory loss often dermatomal. Yes. Motor symmetrical in the conus medullaris. Hyperreflexia paresis less marked than coda equina, maybe fasciculation. So it's upper motor mainly in the coda equina. Areflexia paraplegic, reflexic paraplegic, asymmetric more marked than conus medullaris, fasciculation rare, atrophy more common, conus medullaris more frequent. The impotence is more frequent in the conus medullaris, and the coda equina less marked. Sphincter dysfunction, urinary retention, atonic anal sphincter present early in the disease, can cause overflow urinary incontinence, while in coda equina urinary retention usually present later in course of disease. The low back pain more marked in conus medullaris, while in coda equina less marked. Thanks, Dr. Amin. You can share it as well to the WhatsApp group to be more beneficial. So if no more question, we can move to communication. Dr. Tanya and Dr. Tanvir, are you ready?
Yes, I'm here. Yes, I'm
Yeah.
here.
Okay, Dr. Tanvir.
Yes, doctor. Yes,
Yes,
doctor.
please.
Yeah.
Yeah, arrange together. Who will start first and give the case, please?
You will give me here?
Okay, I'll give you. Or you want to give?
No problem. You can give me. Then I will give.
Okay, I'm sharing in the group.
Okay.
Yes, I share.
Okay.
Dr. Tanya, read it loudly, please, before starting. I share it to the chat box here.
Okay.
You can read
Mr.
it.
Jack.
Yes.
Mr. Jack, 35 years old. He has been complaining of fever, productive cough, and loss of weight for the last 6 weeks. Chest X-ray, acid was bacilli, and TB PCR revealed a diagnosis of active TB. You are a senior house officer of the medical department on call today. So you have been asked to discuss the result with Mr. Jack. 2 minutes.
Yeah, you can read it in the screen. All candidates can read it. You can see in the screen.
Dr. Tanya, ready?
Yes. Hello there.
Yes.
This is Dr. Akhtar from Medical Department on call today. May I confirm I'm talking with Mr. Jack?
Yes, doctor.
Mr. Jack, we are here to discuss about some issues related to your health condition. Is that okay with you?
It's okay, doctor.
So, do you want anyone else to attend the meeting with us?
No, it's okay, doctor.
Okay. So, Mr. Jack, before proceeding further, may I know how much do you know about your condition so that we can be on the same page?
Yes, doctor. Actually, I'm suffering from cough and I'm feeling tiredness and I feel that my body, I'm losing my weight. And for this, I went to the doctor and he did some chest X-ray and some blood test and my leg test. I want to know the result. What happened with me actually?
Okay, okay. So, may I know what is your expectation from our meeting today?
I think this is something simple infection which can be cured by the antibiotic, something.
Okay. So I'm really sorry about your suffering, Mr. Jack. Actually, yes, as you have mentioned that you have that cough and this loss of weight. So we have done some phlegm test and image test and blood test for you, and the result has been released. And I'm afraid, Mr. Jack, the results are not as we hope.
What happened, doctor? What do you think?
Mr. Jack, actually, you have a kind of infection of your lungs by a bug that's named as Mycobacterium tuberculosis. Do you have an idea about this infection of this lungs?
No, doctor, I heard that somebody affected by this infection and they got died. This is too much serious. I heard it's lots of people died for this reason.
Okay, Mr. Jack, I appreciate your knowledge, and I'm really sorry for this condition. So, but if you allow me, I will discuss a little bit more. Do you want to know more about this infection?
Yes, doctor, tell me this.
Okay, so actually, this is a kind of bug infection that we are telling actually the tuberculosis or TB. So it's infecting your chest tubes, and that is causing all these symptoms that you are having, like that loss of weight and fever. And yes, you are right. This is a serious infection. If it is not treated properly only, it can be fatal. But the good news is that with proper treatment, it can be cured fully. But yes, if it is not treated, then it can go to breathing failure. There could be collection of fluid in the lungs. It can be spreaded to other parts of your body, like heart to brain. Are you following me, Mr. Jack?
Yes, doctor.
So don't worry, we are here to give you proper management plan with our specialized team, including our chest doctor and infectious doctor, social nurse. So if you allow me, I will explain you a little bit more about our management plan.
Yes, doctor, tell me this.
Yes, so Mr. Jack, we will treat you under a specialized team, as I have mentioned, that will contain our chest doctor, and we will admit you, and we will do your phlegm test again, and then you will be admitted in a side room till your result released. Okay, because it is a very contagious disease, Mr. Jack. So we don't want to be infected other people around you. Are you getting me, Mr. Jack?
Yes, yes, I'm getting you. But how many days I need to stay there?
You need to admit till the test results release. The decision will be made by the team if you need further admission or not. Are you getting
Okay.
me?
Yes, yes, I
Okay.
understand.
Yeah. So some other factor actually, as you know, it is very highly infectious. It can be spreaded from you to other people by air droplet. So yeah, we need to trace and do suitable tests for nearby people who was in contact with you, like your kids or close contact. So we are going to inform the preventive medication team, and they are going to conduct the tracing, and they will do further management. Is that okay?
Yes, doctor.
Okay, and also we are going to notify our infectious disease team, as it is a contagious disease.
Yeah.
Are you following me?
Yes,
Okay.
yes,
So
yes.
do you
I'm
have
listening.
any other concern, Mr. Jain?
Yes, doctor. I want to know that how many days I need to take this medicine.
Mr. Jack, usually the treatment actually 6 months. I mean, usually it is around 6 months to take this medicines usually, but it still depends if it has spread to other organs or not. Okay, but regarding this medication, I have some information that you should know about. Should I go further?
Yes, yes. Tell me, please.
Yes, as you know, every medicine has actually benefits and side effects. So the medicine that the team might be started with you had some side effect also. The benefits is that, of course, it will cure your infection. It will kill the bugs from your chest tube. But as I have mentioned, that it could have some side effects. So it could, I'm sorry to say that it could affect your liver function. It could affect your loss of sensation in your legs or arms, or a change the color of the secretion. Even sometimes it could affect your vision. But please don't worry. It doesn't mean that we are going to give you the medication and leave you alone. You will be totally under our close observation. So any kind of side effect, please be sure we are here to treat that immediately. Is that okay with
Okay,
you?
doctor. Yes, I understand, doctor. So give me this medicine. I will take at my home place.
I highly appreciate your concern, Mr. Jack. As you have been told that actually this is very contagious. So think about your family members, though they are precious for you, right? So if you now just go to your home, there's a high chance on the way you could spread this disease, and even at your home. So it would be wise to be admitted till this bug is totally removed from by this medication. Are you getting me, Mr. Jack?
Yes, I understand. But I have separate room, separate washroom. I think it's not problematic for my family member. I can make my isolates for that time period.
Okay, may I know why don't you want to get admitted?
Actually, I don't want to be isolated from my family members and from other person. And as you said, you are giving me medicine in the separate room, so I can arrange at my house the same thing. It's okay for me.
Okay, so if you insist, then there has to be actually some criteria that to be met if you want to be home isolation. It is possible, like if you really have a separate personal room and your separate personal stuff and washroom, and it has to be make sure that there is no one in your family with pregnancy or low immunity, like cancer patient, pregnant patient. Are you getting me, Mr. Jack?
Yes, I understand, doctor. No, actually,
So,
there is my small kids. Otherwise, no problem.
uh, for kids, as you know, they are precious for you, right? So if their immune system is low, it will be difficult. So if you can properly maintain this isolation, this is possible with home isolation. So we will evaluate that and we will let you know. Is that okay?
It's okay, doctor.
Okay. So Mr. Jack, do you have any other concern?
No, it's okay, doctor.
So, Mr. Jack, may I ask you some question? Do you smoke?
So yes, I was previously smoke. No, not.
So, as you know, smoking is injurious to health, and it is more injurious to your chest. So, as you are having already one chest infection, I would advise you rather to stop it. If you want
Okay.
any help, yes. Oh, thank you, Mr. Jack. And do you drink alcohol?
No, occasionally. Social.
Uh, so what do you do for your living?
Actually, I'm taxi driver.
Okay, so we could arrange about this with your social worker to help you regarding your earning. Is that okay? Do you need any kind of help?
No, it's okay, doctor.
Your
Okay,
time
so
is up.
Mr. Jack, I'm going. Okay,
Yeah, time is
so
up.
I'm going to give you some brochures. Okay,
Yeah.
thank you, Mr. Jack.
Okay. Okay, thank you.
Okay. Yeah, let's hear a comment from Dr. Tanvir, then we will comment. Let's start with Dr. Tanvir.
Yes, Dr. Tanya did well, and almost all the point she touched. Actually, this is news of the breaking bad news. First of all, that patient suffered by tuberculosis. Some need to tell regarding her condition, his condition. And Dr. Tanya did well. He said by maintaining the proper warning shot and silence about the tuberculosis, and she explained about the tuberculosis and if it's not treated, what happened. I mean, what type of the complication can happen. And also, she said about the treatment, mainly treatment of multidisciplinary team, and also the important thing is notification. She also mentioned that. And also, she said about that isolation and inside room. Here, actually, one point when I asked her that how many days I need to stay there. So she said, okay, we will start treatment, and according to the your progression, it depends. But here, one point I can mention that you need to stay at least 2 weeks or until your sputum become negative. Are you getting that, Talia?
Yes, yes, yes. I told like
Yes, I
the
said,
phlegm test released.
yes.
Yeah,
But I asked about the duration, how many days I need to stay there. So there they to mention that at least you have to stay there 2 weeks. And at the meantime, we will do investigation and we'll check your phlegm test. And we need to see that it's free from your bugs or not. So this is one thing. And after that, yes, she said about the medication. I asked how many days I would take the medication. She said yes, 6 months. But according to the condition, maybe it's need more time. And about the common complication, what can happen by this medication. And the screening, she asked about the screening, like common family members who are the contact, they need screening, and maybe if positive, so we need prophylactic medication. So prophylactic medication need to mention here. It's after doing that screening, if it's positive, we need to give that some medication. And after that, it's showing empathy, sympathy. She expressed proper empathy and sympathy. Social experience, she asked that as I'm telling that I'm a taxi driver, so of course, if I do driving, it will be contagious for other person. She said about the social worker, and she asked also about because patient is insisting to go home. So she asked
Hmm.
about the home environment, like especially the pregnant or immunocompromised patient or small children. They have low immunity, so they have more chance to develop the tuberculosis. But a patient assured that there is a separate washroom and that room, so he can maintain the isolation. Okay, so if patient is adherent, more adherent for isolation, and if she committed that he can maintain, and if there is a no person for immunocompromised or low immunity person or non-pregnant person, so can be home isolation can be done. But if he is confused or if he is not sure that he can maintain or not, that time of course we need to tell about that hospital isolation. And even if he starting more bargaining, no, I will not go. Even he will not maintain the home isolation or hospital isolation. So that time we can offer him that okay, we will arrange a meeting with our consultant to discuss regarding about that issue. If it's totally disagreed for any type of the isolation. And yes, also if there is a time, need to ask about the summary that what he get from this meeting today. And after that, leaflet and brochure that the patient will share. So it's okay. The Tanya did well, and almost all the point she touched. Thank you.
Yeah, thank you, Dr. Tavir, for the scenario. It's common scenario and a major and complex one has more of the data and checkpoint to be checked and data to be asked. So let's start from the beginning. Dr. Tanya introduction was great, but the invitation here is unwise because the patient already infected and he will be infected for the a company. So it's not wise to invite someone here. It's better not to invite. Even it's breaking bad news, but since he has infection, better not to invite. The knowledge about the condition, expectation, and the golden silence and being sorry before informing the result and sorry for the suffer. Then the breaking bad news. Uh, the infection, I wanted here better to mention it's serious infection, just for the seriousness to be serious with the patient and the seriousness of the condition need to be adherent for the medication for the long time because he will be bored with this medication for the long time. So better to mention from the start, it's serious infection and with superbug called tuberculosis. Let's abbreviate it as TB because you will mention it many times. So it's called Mycobacterium bacteria, TB, tuberculosis, and let's abbreviate as TB. Yes, as you mentioned, the complication is affecting the lung, making it scarred. Before breathing failure, the lung will be scarring, and he knows a little bit about the disease, but to mention the breathing failure, can explain how it will be failure because the lung get scarred and with the time might be in failure. So, and as you mentioned, it will be spread to other organs according to the immunity or the defense system. However, good news, it's cured one, but need to be adherent to the medication for a long time. He will ask you the duration, as you mentioned. Yeah, it's long time, maybe reach to 6 months, and in certain condition, if spreading outside the lung, it might be more than 6 months. Okay, the team will be involved, chest and so on, and will be admitted to the aside room. You will invite the infection control team and the infectious disease to be notified about the condition and for people tracing or contact tracing for the last period. How long to be isolated? Yeah, as Dr. Tanvir said, it's 2 weeks and you will be assessed again for the bug inside your phlegm and we will decide upon that. Doctor, I want to be isolated at home. Yeah, it's your right. However, better to be isolated in our hospital. However, if you have some certain circumstances about your room, you can be isolated. What is that thing? As he said, single room, single with the washroom, and you should mention the ventilation. The ventilation of the room should be having good ventilation, window, AC, or whatever the way of ventilation, but should be well ventilated. Try to use mask at home and in certain condition if someone will be closer to you while taking food from, for example, don't be in close contact with your wife. Your kids are susceptible for infection because of the weak defense system. Finally, the smoking and the social support. The alcohol here is very important because there is some interaction between alcohol and anti-TB. Even he's drinking little, you should advise about alcohol to be stopped. The job as usual. If taxi driver never can be, then he will offer help. Yeah, the side effect of the medication, yeah, you mentioned about liver function, deranged liver function, the color of the secretion, especially the water work, the vision affection, sensation, as you mentioned. However, we will follow up you and we will monitor all your investigation and we will manage accordingly. Actually, Dr. Tanya, in general, you did it great. I'm just repeating to be aware about the whole scenario, the repetition only for the teaching, not for criticism. Be sure about that, all of you. I'm not, yeah, I'm giving the points not for negative feedback only. It's always for the teaching purpose. Thank you, Dr. Tanya, Dr. Tanvir. Any question?
Regarding isolation, I have a question actually.
Yeah,
I
sure.
feel like like 2 weeks. Yes, some people there mention that's 2 weeks, but sometimes it's not exactly 2 weeks. You are not even sure. So how I told that your test will be there until
Yeah,
your phlegm test coming negative. It will be. Your film test released, then we will decide actually that he will be gone or not, right? That. So I don't know. I feel like mentioning the exact 2 weeks. Is it wise or just to diplomatically answer that we will
yeah.
wait till the
By the way, your answer was not wrong. It was diplomatic answer and correct answer. It will be assessed by the lab or by workup for your phlegm. So it's diplomatic and correct answer. But all of us knows that it's 2 weeks, either at home or at hospital. That's why I'm giving you sure information. It's not doubtful information. It's sure confirmatory or confirmed information. And your answer will not harm you. I agree for that.
I was thinking if second time he was asking how many days exactly, then maybe I could tell it usually are taking around 14 days or 2 weeks.
Yeah.
But before that, I felt like
Yeah. So
Whenever,
yeah, it's
whenever you want to give a time frame, always
yes.
keep range. So you can tell him it can be up to few weeks. So this is like you have mentioned the time frame because some people they become sputum negative. They take more than 2 weeks, but at least we are talking about weeks. So you can tell him it is like few weeks until we will repeat the sample, and as soon as it is negative, there will be no need for restrictions. Why I'm saying restriction? Because as you said, it can be in hospital, it can be at home. That's why the word isolation is like, it might mean that we will keep you in the hospital. Okay, so there will be no, as soon as your sputum, as soon as the sample become negative, you will have no restriction and you can resume your normal life. We will repeat the test in few weeks. Okay, it depends on the severity of your disease, the extent, whether it is MDR, not MDR, especially that at this point, when you are talking to the patient, you didn't get any cultures, you didn't get anything, so you don't know the nature of the TB you are dealing with. So it's very right, it's very correct to mention few weeks. Okay? And you don't know anything about the strain of the TB you are dealing with. So tell him it's within few weeks. Our aim is to get a negative sample. As soon as we will obtain this, you will be relieved from restriction and you will be able to resume your life. Better to avoid specific number, always keep it range. Few weeks, few days, okay? Like this, up to weeks, no, I mean weeks up to month, okay? Always keep it range. Because in the new marking sheet, which was not there in the previous marking sheet, if anyone has, compare between both of them, they added a new point that you have to provide a time frame. So you have some time to mention, few weeks, from weeks up to month, like this, but keep it always range.
Okay, thanks, Dr. Ahmed. Yeah, thank you. So if no more question, Dr. Tanya, please write your scenario for Dr. Tanvir.
yes.
You'll share in the group or in the chat box?
I will share in the chat box. Is it okay?
Okay,
Or in
it's
the
okay.
chat
As you
box I
wish, no
already.
problem.
shared in the chat box.
Okay. Just a minute.
If you can read it loudly, Dr. Tanvi.
Okay. Miss Lisa, 30 years, admitted with the pneumonia 2 days back, and 2 hour back had seizure because the epilepsy drug was missed. She is non-epilepsy and well controlled for years. Sit with her and answer her question and concern. Okay, just a minute.
Yes, sure.
Okay, I think we can start.
Okay. Timer, please.
Uh, will I start?
No, timer. Dr. Asim will set timer.
Dr. Basim there?
Hello, Dr. Basim.
Dr. Basim. Dr. Basim, I think not here. Yes, you can.
Disconnected.
Dr. Basim here?
Yes, you can hear me now?
Yes, yes. You can start the timer.
Yeah, please wait a moment. Dr. Tanvir, give me a minute just to
Sure.
Yeah,
reconnect.
take
I
it.
have internet. Yeah, I am back. Sorry for the delay.
It's
Better,
okay.
Doctor.
You can see the timer. I will start now. Yes.
Yes, start, please.
Okay. Okay. Hello, madam. I'm Dr. Ali, one of the doctors in this clinic today. Can I confirm your name? You are Miss Lisa, 30 years old.
Yes, doctor. I am.
Okay, madam. Madam, today I came here to discuss regarding about your health issue. Is it all right for you?
Yes, doctor.
Okay. Do you want to keep anybody with our meeting today?
No, doctor. It's fine.
Okay, madam. So, madam, can you tell me that what you know about your health condition?
Doctor, actually, I had a fever and there was problem with
Mm-hmm,
my breathing. So
mm-hmm,
before 2 days, they did some image of my chest and they're telling there's some
mm-hmm,
lung infection. But
mm-hmm,
they started some medication. I don't know, just
mm-hmm,
today before 2 hours, I
mm-hmm,
had one attack of my fits. I'm really astonished why I'm having this because
mm-hmm,
I have this fits since
mm-hmm,
uh, many years. But I'm taking my
mm-hmm,
medication regularly. Usually it is not coming.
mm-hmm,
So I don't know what happened. I just had one attack before 2 hours.
mm-hmm. I understand your situation, Miss Lisa, and I'm really feeling sorry to hear this news. So, what's your expectation from our meeting today?
Yes, doctor, I want to know why this fits coming because of this infection, this side effect, or what happened. I don't know. I want to know why I'm having this.
I am appreciating your concern, Ms. Lida, and actually, I'm really sorry to say that yes, you are right. You are coming here with the chest infection, and at the same time, you have history of the epilepsy. You are taking medication regularly, but I'm really sorry to say that, and I'm feeling afraid to tell you the news.
Yes, doctor, what happened?
Yes, I'm really sorry, and I'm showing my apologies from all behalf of my team. But actually, that what medicine you are taking to control your epilepsy actually it's missed.
What? What are you telling, doctor? You missed my medication? How are you gonna take care of me? I can't believe that.
I understand your mental condition. This is nobody can actually accept these things. I understand that you are controlling your this epilepsy for a long time, but unfortunately, one of your dose is missed, and we thought that due to that missing dose, it's happened. And I'm really sorry to tell this news, Ms. Leda.
How can they forget about this dose, doctor? Give me the name. Whom is that? How they can be this much irresponsible?
I'm highly appreciating your concern, Ms. Leda. Yes, I understand your mental situation. And actually, this is we are what we are doing for you. It's all by our teamwork. Actually, no person individually responsible for these things. But I can assure you, we will take best preventive measure that further this type of the occurrence will not happen. And at the same time, we will write the incidents report and we will involve the patient advisory liaison committee to find out what happened actually with these things. And also we will involve patient risk reducing committee so to prevent the further this type of incidents. Are you getting me?
Yeah, but how it will help me, doctor?
Yes, actually, yes, it's your what you asked. This is the right question for you. Yes, We will do follow up properly and what happened with you. And for the future time, we will take our best care not to have these things. And I just want to assure you, we will involve our brain doctor and physician, specialist nurse, and social worker, and we will regularly follow up you to prevent further attack of this epilepsy. And we will continue with other medication properly. Are you getting me?
Yes, doctor. Yes, doctor. I'm getting you. But I want to complain, doctor.
Yes, I'm appreciating your concern. Yes, you have full right to complain. We can involve the patient advisory committee, and you can put your complaint paper there, and we will find out actually what happened, why this dose missed, and also we'll involve our risk management team to prevent the further this type of the incidents to not happen to the other person also. And I can assure you we will regularly follow up you, and you are under a full follow up, and we'll give our best support to you to see this type of the attack again happen. Not, and if anything happen, of course we will give you the best support. Are you getting me?
Yes, doctor. Yes, but give me. I want to complain against the exact name. Give me the name of the staff, doctor. Why you are not giving the
Uh,
name?
Actually, I understand your situation, Ms. Lisa. Actually, we are doing this work by as a teamwork. Nobody individually is responsible for any mistake. So it's actually our total teamwork. Are you getting me? So we cannot provide the simple individual name in that situation.
Okay.
I understand. Okay, if you give me permission, I will continue some other things regarding
Yes,
your
doctor.
issues. Is it okay?
Yes,
First of
doctor. Yes.
all, I just want to know that actually, if you don't mind some personal question, actually, what's your profession? I mean, what you are doing for living?
Doctor, I'm driver.
Okay. I understand the situation, and I'm just sorry to tell you that obviously as you affected by the seizure attack, so it will be risky for your driving. So I just want to tell you that you need to stop the driving and you need to inform the DVL. Are you getting me?
Yeah, doctor. That's why I'm getting angry because I know that I have to stop driving. That's why I got more angry. How could they be this much irresponsible?
Yes, I understand your situation, Ms. Lisa. So in that case, we will involve the social worker and also occupational worker so they can arrange for you the alternate something so you can maintain your daily living cost. And it will be also helpful for you and also helpful not to make any injury to the other person. Are you getting
Thank you,
me?
doctor. Yes, thank
Okay,
you,
I just
doctor.
want to
I
know
just,
some other things that if you don't mind, are you pregnant now?
no, doctor. I'm not.
Okay, if you are you any wish to pregnant in the near future?
Near future, yes. I have plan actually.
Okay, so I just want to inform you that if you as you are planning for pregnancy, so during that time you need to consult with our woman doctor and also brain doctor for proper management of the medication because you know that some medication actually harmful for the unborn baby, and even if you not continue the medicine, there is another problem for you. I mean, again that epileptic, I mean seizure attack can happen, so you need to adjust the medicine. Are you getting me?
Yes, doctor. Okay, okay.
And another thing, I just want to know that are you taking any medication, especially the any birth control medication or any other medication?
Right now, no.
Okay. And I just want to just award you. I think maybe you also know about these things that you know that if anybody has history of the epilepsy or seizure, they need to maintain some precaution. I mean, they should not go near to the fire and to the high place, or should not go to the swimming alone, or should not go to the washroom and lock from the inside because it can happen any type of the injury or any type of the incidents. Are you getting me?
Yes, yes, doctor. I know all of this. I know about this risk.
Okay, thank you. I just want to know that are you financially supported? I mean, who is living with you at the home? Anybody support you?
As I told you, doctor, I'm driver. So I have family. I have my husband.
Okay. So you are
So yes, I'm
financially
well supported.
yourself.
Yes,
Okay.
yes.
Okay, nice to know that things. Any other more concern, Ms. Lisa?
No, doc, thank you. It was a great
Uh, uh,
meeting,
yes.
but now it's okay.
Yes, I want to tell you again, sorry, because I understand what happened with you. It's really unexpected, and I am feeling again sorry for all the behalf of my team. And I will give you some leaflet and brochure and our contact number and website address so you can read more about the thing and how can prevent further attack of the seizure. And you can contact anytime with us by our contact number. Is it good for you?
Okay, thank you, doctor. Thank you.
Can you tell me that how much you get from today's our meeting?
Yes, doctor, as you guys have missed one of my medication. So now you are telling that I can raise the complaint, and also you will treat me with the
Time is
nerve
up.
doctor again, brain doctor again. Okay, thank you,
Yeah,
doctor.
Welcome.
time is up. Okay, let's read the comment from Dr. Tanya. Yeah.
Yes,
Yeah.
very well done, mashallah. Uh, just a few comments. Overall, he did very great job because it is a case with hidden so many agenda, and at a time coming the patient, it's very difficult because touching each and every hidden agenda within this 10 minutes is difficult. But you did great, mashallah. So just a little bit, a small comments that I noticed. You didn't mention your own name. You just told that you are a doctor, but you need to mention your name, your introduction, and the name of the patient. It was Mrs. Lisa. So in between, sometimes you told Miss Lisa. So these two things actually very important. They are marking the introduction and how you are reminding and remembering their name properly or not. This is the important thing. Other than that, you started and everything you did very well. I just wanted to hear one word actually from the first, the apologize, the word. You were sorry, obviously, and you use the word at the last moment, so it is okay. You apologize because it is an error, so it should be taken as a mistake that yes, we did, but it was unacceptable. But yes, you were sorry very times. And one thing that you involve pulse by yourself at the first time, at the first step, you involve yourself the pulse actually you shouldn't involve. If first time I'm telling that as you already answered me that first time when I want to complain, you defend, not defend, you try to make me convince. Then second time, yes, you told me to pulse. It is the perfect way. But somehow you mentioned the pulse at the first moment by yourself when you were telling about the incident report and pulse at a time. So pulse actually it should not be uttered from your side at the first time. Till the patient is telling about complaining, I feel like that. I could be wrong. Others will clarify me. And yes, you told about the team that is maintaining, that will maintain again. The brain doctor will, you involve brain doctor. That's a very good thing because he needs review of the medication again. And the one important thing that all the hidden, the red alert that regarding my driving and dependency, all the risk environment, you touch each and everything just to think. I think you just missed somehow because it is supposed to be so many things. Smoking and alcohol, these two things you didn't ask, but mashallah, you asked me about even my OCP and everything else. So it's a very nice, small things. Other than that, it's very well coordinated and nicely done. Thank you.
Yeah.
Thank you, Dr. Tanya.
Yes. Thanks, Dr. Tanya. Thank you, Dr. Tanvir.
Yes, actually, I forget to mention the smoking and alcohol because so many things need to ask, like especially driving or pregnancy, and also patient already get the seizure. So even further seizure attack can happen. So we should again mention that what are the precautions need to take because maybe patient know, maybe don't know. And also, as we did mistake, we have to tell so many times sorry. Actually, initially I said sorry. Again, in the ending, I should say again sorry. But actually, why I involve the pulse with the incidents report together? Because patient, when she heard that we missed the dose, she already like a little became looks like angry, and she asked who did that mistake. I want to know that person. That actually to convince the patient, I said some other things to preventive and risk management team, and what are the steps we will take. Because I'm thinking that if we tell only incidents report, maybe patient will not satisfy. So we need to tell that what are the multiple steps we will take the maximum protection. And as patient asked me that, okay, I want to make the complaint. So that's why actually I involved that pulse skill.
Okay, thank you, Dr. Tanvir. Well performance. Some few comments, and I will comment on the case totally, and you can please accept this advice. Okay. So the introduction, the invitation, the knowledge and expectation was great. The breaking bad news that like you did a mistake. I can say, yeah, admit the mistake, not breaking bad news. So admit the mistake from the start and acknowledge that and immediately apologize, as Dr. Tanya said, apologize for the whole scenario. And the immediate action taken, which is we prescribe the medication again and we give it to you, and it's in the system right now after we discover this mistake. And the steps of medical error should be full, like incident report and the root cause analysis and the meeting with consultant should be done, all of them, because this is medical error and already happened, the mistake happened. So in order to prevent it from happening again and for your care and for another patient care, we did these steps in order to provide the maximum care for and services for our patient. So when she asked you, give me a name of this missing stuff. Yeah, we are a team. I can't give you. We are doing our work as a team. I'm so sorry. I can't give you a name. Don't guide her to the paths from the start, as Dr. Tanya said. I agree with her. Even she's angry, even she has the right to complain. But your job here is to absorb the anger for the patient and to convince her. And at the end, this is her right, but not the first step. So whenever you convince and she is not accepting, it's okay. Guide her to the paths, but don't offer it from the start because the consultant will say, what is this doctor? Every mistake, he will just guide the people to the PALS office immediately. So why you are here? You should do some action and to convince the patient. Yeah. Apart from this, you did the red flags work, the social support, the job and driving, but you missed the smoking and alcohol, and you remember pregnancy and OCP, which is somehow weird. I forget the pregnancy and OCP and smoking alcohol. I could remember, but it's okay. All of them are important in childbearing period. However, she should be on some safe medication. It will not be only this time will be on medication or anti-epileptic will not be safe for her pregnancy if she's willing for pregnancy. I guess so. Anyway, you can cover this point. It will be more safe to mention it or to mention them. And the red flag as well. Finally, the leaflet brochure and always being sorry for the mistake is very important. Yes. Thank you, Dr. Tanya and Dr. Tanvir, for nice communication cases.
Yes. There is a nice
Yeah.
question asked by Dr. Tania that
Yeah.
that all the measure you are taking, but what is the benefit of me? This is very nice question. Because
But,
we will take the preventive care for further not happen to other patient. But what is the
ye-
benefit of me? Because I get already seizure attack. This is
yeah.
very nice question. And that's why
Yeah.
I told her again that yes, for you, I mean personally for you, we will take the best care and we will arrange best follow-up team for you that this type of the
Yeah.
seizure will not happen future because she wants something personal benefit. This is very nice question. I appreciate it.
Yeah. Yeah.
Yeah, and
Always
also
put,
you answered it very well. I wanted to
yeah.
Thank you.
hear that answer. You comfort me. It was nice.
Yeah. You will irritate her if you say just for other patient. Yes, I agree. So put here always in the priority and for other patients. Yes, you're right. Yeah. Okay. Any other comment, Dr. Tanya, Dr. Tanvir? Okay.
No, it's okay
No.
for me.
Okay. Thank you. Any question from all colleagues?
Assalamu alaikum. I will comment a small comment,
Alaikum
Dr.
salam.
Basim. Excuse me,
Yeah,
please.
Dr. Hunaida. Yes, welcome.
Yeah, thank you. Well done, Dr. Tanvir, actually. Only one thing, in medical error, no need for summary and recap. I heard you ask her for recap at the end of the scenario, so you
Yeah.
will make her angry again and again. So better
Yeah.
to repeat your apologize and sorry at the end, other than summary and recap. That's all my comments.
Thank you, Doctor. Thank you.
Thank you.
Yeah. Thank you, Dr. Hunaida. You discover a hidden point we didn't discover. And please attend with us. Your attendance is vital. You're just fresh past the exam, so still the knowledge fresh with you. Share it
Yeah,
with us.
thank you.
Okay, thank you, Dr. Hunaida. Any other comments? Any question? Okay, so we can end the session to nominate for tomorrow participants. Yeah, Dr. Dalia, question. What about the medical action? I might be away.
No, he mentioned,
The
Dr.
med-
Talia. He mentioned about brain doctor, social worker, about the
what the,
medical.
I don't know what the meaning of medical action, Dr. Dalia. You mean the action after the mistake?
I
Yeah,
mean, there. I think he's asking medical, legal. No, one legal actions he told. Medical also he told. Actually, he already told that we will involve brain doctor, social worker, and they will see you, observe you, like that. Yeah, he was asking that because there are two parts actually in the error, right? One is the medical part, and medically action I'm going to take, and legally some action we are going to take.
yeah. So the medical action, the medication, resume the medication, right? And the
Yes,
legal action,
involving
the
that MDT team. MDT team here actually
yeah,
already he
sure,
is under
sure.
chest
Yeah.
doctor and brain doctor. He
And you will
mentioned
call me
already brain
brain doctor, yes, as well, yes.
doctor.
And the legal action, which is the medical incident report and so on. Yes.
Yes, all the
Okay.
root cause analysis,
Yes.
draft
Yeah,
signature,
both.
all
Yeah, meeting and so on. Okay.
meeting, mortality,
Any
morbidity
quiz?
meeting.
Yeah. Okay. We'll put you on regular follow-up as well. Yes, this is for the future. Always be safe for the patient and the patient welfare, just to show the examiner. Okay. So we have volunteer from now. Dr. Nusa tomorrow can be candidate for communication. Sure, Dr. Nusa, we'll take the nomination now. I will just end the recording.
I
Then
also want
yeah,
communication if there's no Dr.
yeah,
Nusa.
sure. Okay. So we had it already for tomorrow. Remains the long case. I will end the record, then we can nominate. Thanks all for the attendance. Thank you for a nice session. Yeah, Dr. Yeah,
Thank you,
safety
Doctor.
netting
Thank
he
you.
mentioned. Thank you, Dr. Yeah, he mentioned safety netting, Dr. Dalia, in the form of swimming or washroom, lock the door on behind, and yeah, the medication and the infection also can be given here as a safety netting. High altitude also one of the safety netting. Yes, thank you, Dr. Dalia, for this comment. Okay, yeah. Thanks for the session and attendance today. Nice session and nice cases. Thanks all for participation. I will just end the recording, then we will nominate for tomorrow.
Okay, thank you, Doctor.